So, sir, it's 3, 2, 1. Over to you, sir.
Welcome you all, respected delegates. Today is Diwali, so wish you all a happy Diwali. We are having our privilege to host this course on allergen immunotherapy, the basics of allergen immunotherapy, under the auspicious platform of Indian College of Physicians. So we have the guidance from our Dean, Professor Jyotirmoy Pal sir. So may I request Professor Jyotirmoy Pal sir to have his voice of wisdom. Over to Professor Pal.
Thank you, Dr. Shammu Samazdar, and happy Diwali to all of you. I am very happy Dr. Shammu Samazdar has taken the responsibility of being the course director of allergy and immunology. To say something about Indian College of Physicians, under whose banner this certificate course is conducting, it is a organization of the physicians. I say it's the largest organization having 24,000 members. Indian College of Physicians is the academic wing of Association of Physicians of India. We are conducting different academic course for upgrading the knowledge of the medical practitioner across India, so that it can be translated into better clinical practice. We have chosen those subjects. Those subjects are less discussed in our postgraduate curriculum or in different CME conference, seminar, workshops. So allergy and immunology is like one of them. We also conduct master classes every once in a month. In the master class, now we have renamed as a Global Forum Master Class because the neighbor countries, Bhutan, Nepal, Bangladesh, Maldives, Sri Lanka is joining. We keep faculties from those countries also, so that students from those countries get a taste of the style of teaching of our countries, or our countries also get the taste of style of teaching from those countries. So in this way, we publish also many monographs of some issues of the recent importance. So this short certificate course is like one of them. And we have chosen allergy and immunology, as I told before, that is less discussed. And I am very sure with this course, the students and practitioners will be hugely benefited. Thank you, Dr. Shambhu Samazdar, for taking the responsibility. Over to you.
Thank you, sir. Thank you very much. Thank you for leading us. And we are now moving towards today's lecture. And for that, we are really privileged to have with us Dr. Binoy Mehta. Dr. Binoy Mehta is a board certified allergist and immunologist at California. Sir had conducted multiple clinical trials, phase 3 clinical trials in different therapeutic options in the field of allergy. So today we'll discuss about history taking and clinical methods in airway allergy. So already from the previous class, we know the importance of history taking. So today we will learn from Dr. Mehta about the arts and science of history taking and clinical methods in airway allergy. We have a 1 hour lecture first, followed by we will have panel discussion with distinguished panelists that will be started from 11. So may I request all the participants, all the respected delegates who had joined, please go through your WhatsApp group and mail. You already get one link to submit your pre-test answers. So please click on that Google form and submit your answer. We will have similar type of post-test after this session. So now again, we are delighted to welcome Dr. Binoy Mehta. Over to sir, please.
Okay, thank you, and happy Diwali, everyone. This is On behalf of the organizers, I want to really thank you, Dr. Shamardar, for inviting me to this esteemed panel. And what I want to discuss over the next, maybe not 1 hour, but maybe 45 minutes, is really, I think, a very key concept. And that is how to take a proper history. So we'll talk about history taking as it pertains to airway allergy, and we'll also talk about different clinical methods of evaluating airway disease. And again, this is a very basic talk, but it's a very fundamental talk. So I would encourage you to please pay attention. If you have questions also, please enter it in the chat box. We will try to answer as many questions as we can. I'm actually a practicing allergist from Allergy and Asthma Associates of Southern California in Irvine. And actually, we have our annual allergy conference right now in Anaheim. So today I was at an allergy conference, and it's being conducted over the next couple of days. So I'm very delighted to be here. And so in terms of background information, history taking is extremely critical to making an accurate diagnosis, especially in terms of allergy. And I think it's important to emphasize that history, rather than tests, is really the cornerstone for diagnosis and management of allergic airway disease. Again, I think it's important to repeat that history is really important. I think that's one of the challenges that we have, because we have different diagnostic tests, and oftentimes the physician is busy in the clinical setting, and history is something that we sometimes forego. So I think it's worth repeating that history, rather than tests, are really the cornerstone when you make a diagnosis, and also how you manage these patients with allergic airway disease. Also, it's important to realize that when you take the time to conduct a good history, it helps establish a therapeutic relationship with the patient as well as the family. And this is very critical, especially when we're prescribing medications for long-term diseases such as asthma. It's important that the patient and the family feel comfortable with you. They feel that you're really taking the time to help understand them. It's also important to put patients at ease, so they feel free to ask questions, to clarify any doubts. And so it's very important not to gloss over this. And I think history is also important because it informs the need for additional investigations. If you spend time taking a good history, then you know what test you need to get, and so you don't waste time with unnecessary tests, unnecessary investigations, unnecessary costs for the patient. So taking the time is important, but also asking the correct questions is very imperative. So in terms of what we see as allergists, allergic rhinitis and allergic conjunctivitis, as well as asthma, those three things are the key airway diseases that are treated by allergists. And it's important to emphasize that the treatment guidelines for allergic rhinitis, allergic conjunctivitis, and asthma are determined in large part by the severity of symptoms and impact on quality of life. So it's really important to get a good assessment of what is the severity of symptoms, what is the impact on quality of life, because that will determine how aggressively you treat these disorders. It's also important to know that these two diseases, allergic rhinitis and asthma, are highly correlated. What we call united airway disease. For example, up to 40% of patients with allergic rhinitis have asthma, up to 80% of asthmatics have allergic rhinitis. And we know that treating allergic rhinitis can improve asthma symptoms. It can help reduce exacerbations, it reduces ER visits, hospitalizations. It also decreases bronchial hyperresponsiveness. So it's very important when you're dealing with airway disease to think of the upper airways and lower airways as one disease, and to be very attentive to this when you take a clinical history. So the other concept that's also important is understanding, the overall context, the atopic march. So when we talk about atopy is a genetic tendency to develop allergic disease. Allergic rhinitis, asthma does not occur in a vacuum. It's usually part of a broader picture. And oftentimes these atopic diseases occur in families. So family history becomes very, very imperative as well. Now, there's this concept of atopic march. When you think about different allergic disorders, typically there's a certain order in which they present. So food allergies generally present early in life, between birth and 12 months of age, and followed by atopic dermatitis, which is what we call the entry point. That typically starts at age 3 months and goes on to age 3 years. And then asthma. Then we see asthma typically by age 3. And then later in life, we see allergic rhinitis typically by age 7. So knowing these things is important. So when you take a history, based on the age of the patient, these are the things that you need to be thinking about. These are things that you need to be aware of. And it's important because early intervention, there's good data that early intervention may actually help prevent further progression in the atopic march. So for example, if you see a child with atopic dermatitis, and if you treat the atopic dermatitis aggressively, then there's a good chance you may actually help reduce the risk of allergic asthma. You may help reduce the risk of allergic rhinitis. You may help reduce the risk of food allergy. So this is very important to intervene early to prevent progression of disease. In terms of the epidemiology of airway disease, well, what are the risk factors for atopy? So that's also very important. When you take a history, we know that positive family history is important. Male sex, so boys tend to have atopic diseases earlier in life. Then usually by the age of 18, then things normalize. Then the prevalence is same between male and females. But early in life is usually typically males. Also, children with elevated serum Ig levels are more predisposed to atopic diseases. Sensitization of airway allergens, which we'll talk about, that's really we talk about immunotherapy, so you have to be sensitized to airway allergens. And certain airway allergens, in particular dust mite, cockroach, cat, and indoor molds, are potentially asthmogenic. So these are things that you definitely want to think about. Maternal smoking exposure in the first year of life can also be important, and early use of antibiotics, which we know is rampant now. So these are all factors that can increase the risk for atopic disease. So let's talk about we'll talk about first allergic rhinitis, and then we'll talk about asthma. So when we talk about allergic rhinitis, it's very important first to set expectations to really define what is allergic rhinitis. So allergic rhinitis is a disorder of the nose induced by Ig-mediated inflammation. So it's an inflammatory disease after allergen exposure. So what are allergens? Allergens are typically proteins. So they could be pollens, so tree pollen, grass pollen, wheat pollen, which can result in seasonal symptoms, seasonal allergens, depending on the pollination calendar. Or they could be perennial allergens. Perennial allergens are allergens that are present year-round. So those would be things like dust mite, pet dander, cockroach, and mold. Now, we know that up to allergic rhinitis affects up to 40% of children, so it's fairly common, and up to 20% of adults. And we also know that patients with allergic rhinitis oftentimes they're more prone to respiratory infections, especially upper respiratory tract infections. They're more prone to acute and chronic sinusitis. In children, they're more prone to otitis media, and they're also more prone to asthma. Yet oftentimes allergic rhinitis is regarded as a trivial disease. So we need to change that mindset. Allergic rhinitis is not a trivial disease, as I will mention, as we'll go over, and it's something that you need to be paying attention to. Now, the other question is the timing. So what is the age whereby patients can become sensitized? So sensitization generally occurs to indoor allergens such as dust mite, cockroach, pet dander, molds. Typically does not occur before age 1. So if you see a child under age 12 months, it's probably not allergic rhinitis. It's probably more infection related. And then in terms of pollen, so grass pollen, tree pollen, and weed pollen typically does not occur until age 2 or 3. And so those are important things. So later on, when we talk about skin testing, you need to be aware of that, because you need to tailor your skin test panel based on the age of the child. Typically, the maximum sensitization occurs around age 18. So then afterwards, things generally are stable. Now, in terms of allergic rhinitis, I think it's important to emphasize the cardinal symptoms. So when we ask patients, whether they have allergic rhinitis, well, we're talking about, sneezing, rhinorrhea, nasal congestion, also itching. Itching is important, is a cardinal symptom. Itching it means that you have mast cell degranulation. In the absence of itching, you really have to think about non-allergic rhinitis, which is the other differential. So rhinitis could be allergic or it could be non-allergic. And typically, if you don't have itching, nasal pruritus, then you're probably dealing with non-allergic rhinitis. Now, up to 50% of patients with allergic rhinitis also have ocular symptoms. They may have bilateral itching, tearing, or burning of the eyes, and that's what we call allergic conjunctivitis. So that's in about 50% of patients. Also, other symptoms that are commonly associated with allergic rhinitis are post-nasal drip, cough, headache, and facial pain. In children, especially young children, typically they don't blow their nose, so they may have repeated snorting, sniffling, coughing, and clearing of the throat. So these are also symptoms that you need to be aware of. But it's also important to understand that in addition to cardinal symptoms, a lot of these patients may have secondary symptoms. And these are things that you need to pay attention to because it really ties into quality of life issues. So patients with allergic rhinitis typically may have sleep disturbed breathing. So for example, they tend to snore. Some of them may even have sleep apnea. So that's important to inquire about when you conduct a history. Many patients complain of fatigue, generalized malaise, poor concentration, anxiety, depression, and it's clearly been shown to be associated with reduced academic work performance, work performance. So in terms of learning, they oftentimes are impaired. These children struggle academically. It can affect work performance. It can affect as well athletic performance, and it can cause low self-esteem. So these are all things that you need to be inquiring about when you conduct a history. And so, just an example, this is a study done in the United States called Allergies and Asthma, where they did a phone interview of 2,500 patients in the U.S. who suffer from allergic rhinitis. And as you can see, most of them, had physical symptoms. So congestion being the number one complaint, followed by rhinorrhea, post-nasal drip, ocular symptoms. But on the right-hand side, as you can see, a lot of these patients also had psychological symptoms. Majority of them felt tired, felt miserable, felt irritable. A large percentage of patients felt depressed. And so these are things that you also have to be aware of. These are things that you should be asking about when you take a clinical history. Now, when you think about allergic rhinitis, of course, you have to be also thinking about differential diagnoses. So in young children, you may be, think about adenoidal hypertrophy, which blocks the sinus drainage, which impairs sinus drainage, and that may result in chronic congestion. So think about adenoidal hypertrophy, think about choanal atresia. Also, young kids are very prone to infections, both acute and chronic sinusitis. Also, young kids tend to play around. They may introduce foreign bodies in their nose, in their nostrils. So foreign bodies is very commonly seen, especially if they have unilateral symptoms. And then you also have to think about nasal polyps. So think about cystic fibrosis typically will result in nasal polyps. So these are things that you need to be thinking about. In older children and adolescents, you think about, of course, upper respiratory tract infections, acute sinusitis, chronic sinusitis. Now, when we talk about chronic sinusitis, typically you have symptoms for at least 12 weeks, and you have 2 out of 4 cardinal symptoms. So either anterior and or posterior mucopurulent drainage, nasal obstruction, facial pain, facial pressure, or facial fullness, and typically a decreased sense of smell. So 2 out of 4 lasting more than 12 weeks. That's by definition that's what we call chronic sinusitis. Other things to think about in the differential allergic rhinitis is nares. So nares is a condition where it's called non-allergic rhinitis with eosinophilic syndrome. So these patients don't have allergies, but what they have is a lot of eosinophils in their nasal mucosa. So you have typically nasal eosinophilia, and you have because you have a lot of eosinophils, sometimes patients can even develop nasal polyps. Sometimes they can have a new sense of smell. And so this is one of the differentials of allergic rhinitis. The other common differential is vasomotor rhinitis. So these are irritants that cause the symptoms like cold air, humidity, strong odors, irritants. Think about occupational factors. So think airborne substances in the workplace, like formaldehyde, for example, wood dust, things like that. Depending on the occupation, those can also trigger symptoms. We'll also have to think about hormonal influences, like during pregnancy. Patients with hypothyroidism can also present with rhinitis. Think about drugs, so typically oral contraceptives, antihypertensive drugs, NSAIDs. A lot of the psychiatric medications, the antipsychotics, can also cause symptoms of rhinitis. There's another category called gustatory rhinitis, where it's induced by hot, spicy foods. Also, alcohol can cause nasal symptoms. So these are all things that you need to be thinking about when you take a clinical history. Speaking about drugs, there's one that's very common that is rhinitis medicamentosa, and that's due to chronic nasal decongestion use. Oftentimes, patients who are on nasal decongestants, because these are readily available over the counter, do not require prescriptions, you really have to ask patients, if they're taking anything they're taking over the counter, you need to be aware of. Also think about atrophic rhinitis. So this is something that we see in elderly, where there's atrophy of the nasal mucosa, which is what we call primary atrophic rhinitis. Sometimes patients, especially those who've had aggressive turbinate reduction surgery, they may have secondary atrophic rhinitis, also known as empty nose syndrome, where too much of the turbinates have been taken off, have been removed, and that can also cause atrophy. And then you have to think about anatomical issues. Does the patient have a deviated nasal septum? Does the patient have turbinate hypertrophy, anal hypertrophy? Is there a foreign body? Is there a tumor? Is there a polyp? So these are all things that you need to be thinking about, especially when, typically these patients don't respond to typical therapies. And so this is where you need to really broaden your differential diagnosis. And then you have rare things, sarcoidosis. We know sarcoidosis is a multi-organ disease. It can also affect the nose and sinuses. Vasculitic conditions like granulomatosis with polyangiitis, previously known as Wegener's vasculitis. So the Wegener's is a vasculitic condition. It can certainly cause nosebleeds. It can cause involvement of the nasal mucosa. And then you have things like relapsing polychondritis, which can affect the nasal cartilage and also cause symptoms. So these are some of the things that you need to be thinking about when you take a clinical history. The other thing that's I think is important is how we classify rhinitis. So this is based on guidelines called ARIA guidelines, also called allergic rhinitis, and its impact on asthma. And the way that we categorize severity is basically two groups: intermittent versus persistent. So intermittent would be when patients have rhinitis symptoms less than 4 days per week or less than 4 weeks a year, versus persistent. Persistent would be more than 4 days per week and more than 4 weeks in a year. So first question you want to ask, is this intermittent or is this persistent? And then secondly, you want to ask, is this mild or is this moderate severe? And if it's mild, then basically it means that the patient is sleeping well, there's no interference in sleep, there's no interference with daily activity, sports, leisure, no interference with work performance or school performance, and basically no troublesome symptom. So for all practical purposes, you will never see mild rhinitis, because if a patient has mild rhinitis, basically they don't have symptoms, so they're not going to come to see you. So by the time you'll be dealing with either moderate or severe rhinitis, which means one or more of the items are affected. So either abnormal sleep, impairment of daily activities, sports, leisure activities, abnormal work, abnormal school performance, and troublesome symptoms. And so this is important to really categorize, because this will affect how we treat allergic rhinitis, intermittent versus persistent. It's also important because the guidelines or treatment guidelines suggest that you need to check for asthma in patients with either severe or persistent rhinitis. So these patients who are in this category, should be screened for asthma, because up to 40% of these patients may have asthma. And then, of course, in the context of immunotherapy, when we talk about immunotherapy later in this course, it's these patients who have moderate to severe and persistent symptoms. These are the patients who typically we put on immunotherapy. We don't put people on immunotherapy if they have intermittent symptoms or if they have mild symptoms. All right, so now going to asthma, which is the second biggest airway disease that we see as allergists. So in terms of asthma, it's important to recognize that asthma is a heterogeneous disease, but it's characterized by chronic airway inflammation. And is defined by respiratory symptoms. So what are the cardinal respiratory symptoms? Wheeze, shortness of breath, chest tightness, and cough. And what is unique about asthma is that these symptoms vary over time and intensity. Unlike COPD, where you'll always have symptoms, with asthma, you typically won't have symptoms unless if you have exacerbation. So these symptoms vary over time, they vary in intensity. And in terms of objective measurements, when you do a spirometry, you will see variable expiratory airflow limitation, meaning that if the patient is not having symptoms, the spirometry will be normal. But if the patient is having symptoms, then you may see obstruction, you may see airflow limitation. In terms of the disease of asthma, so it's commonly, as I mentioned, these are typically starts in childhood, but many children can actually experience remission around the age of, around puberty. So they may actually get better, and then there may be potential for recurrence years later. And this is something that certainly we see rising prevalence all over the place, but especially in developing countries, and especially among children, such that the current prevalence of asthma is about 10% in the general population. And we know that asthma is a major cause of school and work absences. It is also associated with a very high morbidity, including death. So every year, we see about almost 500,000 asthma-related deaths. Most of these deaths are preventable. Most of these deaths occur in low to middle income countries. And unfortunately, in India, so in 2020, there were almost 200,000 asthma-related deaths, which represents 42% of global asthma deaths. So vast majority of asthma deaths are actually occurring in India. And so this is something that we need to be aware of. This is something that we need to try to prevent as much as we can. So what are the risk factors for asthma? Having a parent with asthma, either a mother or father, that increases the child's risk of developing asthma. Also having a history of atopic dermatitis dramatically increases the risk of asthma. And then airway allergen sensitization. So typically dust mite, cockroach, and indoor molds increase the risk of asthma. For example, if you're sensitized to dust mite, you may see up to 8-fold increased risk for asthma. So this is something that you also need to be aware of. Other risk factors include tobacco smoke, so either active or passive smoke, early viral infections, respiratory infections, so rhinovirus, RSV, especially if these viruses cause wheezing. That is a risk factor for asthma. Being born premature is a risk factor. Air pollution, especially around diesel particles, and small particulate matter is a risk factor. And recently we know that obesity can also be a risk factor for developing asthma. What are the cardinal symptoms? Wheeze, and we really need to clarify what is wheeze. Wheeze is a high-pitched whistling sound, usually upon exhalation. Cough, and this cough is generally non-productive. It's generally worse at night. Shortness of breath or difficulty breathing, and then chest tightness. So these are the 4 cardinal symptoms of asthma. Now, that being said, in children, you may have a different presentation. In children, they may complain of, they may not be able to verbalize these symptoms, but they'll complain of, or the parent will comment on fatigue, irritability, their chest hurting. They may avoid certain activities. And then in infants, typically parents will notice difficulty eating. The infant may be grunting during sucking of milk. And so you have to be, again, attentive to that. What are the typical triggers of asthma? Definitely respiratory tract infections, exercise, allergen exposure, irritants, whether it's tobacco smoke, cannabis smoke, indoor pollution, outdoor pollution, strong odors. These are all common triggers. Also extremes of temperature and humidity. And then certain drugs. It's important to ask about aspirin, NSAIDs. We know that about 15% of these patients with asthma have what's called aspirin exacerbated respiratory disease. So either if they're taking an aspirin or if they're taking a COX-1 NSAID, it can actually aggravate their asthma. And then beta blockers, especially the non-selective beta blockers, because they can block beta-2 receptors in the bronchial smooth muscle, they can also cause asthma exacerbation by causing bronchial constriction. So we need to be aware of these things in the history. And then stress can trigger asthma, so can pregnancy. About a third of patients who are pregnant, especially in the 3rd trimester, they can have worsening asthma symptoms. Now, this is directly from the GINA guidelines, and I would encourage all of you to read the GINA guidelines as it pertains to, the history aspect. So you have probable asthma if the patient has more than one type of symptom, so wheezing, shortness of breath, coughing, chest tightness, if the symptoms are worse at night or in the early morning, if the symptoms vary over time and intensity, and if the symptoms are triggered by viral infections, exercise, allergen exposure, changes in weather, and irritants. The GINA guidelines also specify that asthma is less likely if you only have isolated cough with no other respiratory symptoms. If you have chronic production of sputum, that may be COPD, that may be tuberculosis. If you have shortness of breath associated with dizziness or lightheadedness, that could be vocal cord dysfunction. It could be anxiety. Chest pain, think about cardiac. Typically, asthma does not cause chest pain. And if you have a noisy breathing, so think about stridor, that's usually upper airway disease. So it could be, like croup, or it could be laryngomalacia, or it could be vocal cord dysfunction. So these are all things that are less likely to represent asthma. And then, of course, you have a differential. So what is the differential for coughing, wheezing, shortness of breath? Again, in children, think about viral bronchiolitis, extremely common, RSV, parainfluenza virus. Think about laryngotracheomalacia, foreign body. That's something, for example, if you have wheezing that doesn't respond to bronchodilator, it could be a foreign body aspiration. Croup, which is more upper airway. Think about bronchopulmonary dysplasia in premature infants. Also think about common things, infections. So it could be sinusitis. We also think about reflux, especially in young children, can present as asthma, vocal cord dysfunction, hyperventilation, cardiac disease. And then in adults, think about COPD, either chronic bronchitis or emphysema. Think about hypersensitivity pneumonitis. Think about medications like ACE inhibitors, which can cause chronic cough, PE, bronchiectasis, cancer. So these are things that you need to be thinking about. So again, not every person with coughing, wheezing, shortness of breath has asthma. So you really need to be thinking about your differential diagnosis when you take the history. The other thing that's also very important in asthma is that keep in mind that the treatment of asthma is really dependent on the level of symptoms and how well the symptoms are controlled. So asthma severity, for example, is assessed retrospectively based on the level of treatment required to control symptoms and exacerbations. So for example, if you categorize the patient as having mild asthma, that means that the patient is well controlled with steps 1 and 2, the GINA guidelines. Moderate asthma would be a patient well controlled with step 3, whereas severe asthma would be someone that requires step 4 or step 5, or who remains uncontrolled despite this treatment. So that's for severity. And then for asthma control is really based on symptoms, control of symptoms and as well as risk factors. So, yeah, this is not an asthma talk, but I just wanted to show you, I want to highlight to you why it's very critical to take a detailed history, because, the level of where you start, how do you know where to start the patient on treatment? It really depends on the frequency of symptoms. So the more frequent the symptoms, the more aggressive you need to be in terms of initiating therapy. Also, if the patient is having nighttime symptoms, so for example, if the patient is having daily symptoms or waking up at night with asthma, then they need a higher level of initial therapy versus a patient who only has daytime symptoms. So it's, again, very important to take a detailed history. How often are they having symptoms, both daytime symptoms, nighttime symptoms? How often are they requiring albuterol or another rescue inhaler? And this is, whether it's whether it's an adult, whether it's an adolescent, or whether it's a child. Again, frequency of symptoms will really determine how aggressively you treat the patient. And then in terms of asthma control, once you start a patient on pharmacotherapy, then you really need to assess how well the asthma is controlled. And again, history is very important here. Essentially, it's based on history. So this is, again, from the GINA guidelines. There are really 4 questions you need to ask. In the past 4 weeks, has the patient had daytime symptoms more than twice a week? Yes or no? Any nighttime awakening due to asthma? Yes or no? Any salvo reliever for symptoms more than twice a week? Yes or no? And any limitation of activity due to asthma? Yes or no? And so, again, to remind the audience, if you have to answer no to all of these 4 questions in order to label the asthma as well controlled. If they have any of these as yeses, then it's either partially controlled or uncontrolled. So that's for asthma symptom control. And then for risk factors for poor asthma outcomes, some of the things that you want to inquire about, for example, are they taking their medications? Obviously, that's important to ask. So adherence is important. You want to ask them, please show me how you take your inhaler. So technique is important. And then you want to ask about comorbid conditions, obesity, chronic sinusitis, reflux, food allergies, pregnancy. These are all things that can hinder and can increase risk for asthma exacerbations. You want to know about their smoking history. You want to know if they're exposed to different, allergen exposure, air pollution. And again, these are all things that are based on history. There are no tests for this. It's simply asking questions to your patient. And it goes even beyond that. So when you look at, sometimes you even have to go back and ask them about birth history. So for example, we know that risk factors for developing persistent airflow limitation is based on, for example, if they're preterm, if they have low birth weight, those are all risk factors. So you sometimes have to go back, even take a birth history. You also want to ask about tobacco exposure, chemical exposure, occupational exposures. So again, these are all things that can only be that can only come out of taking a thorough history. So with that, I'm going to now transition and give you some practical tips of how to go about taking a history in a systematic manner. So, first of all, you ask the patient, okay, what is the presenting complaint? So history of presenting complaint, and here what you really want to do is focus on the age of onset of symptoms, knowing, so going back to this here, you need to know a little bit about the atopic march. So when the symptoms begin, and so, depending on the age, you kind of know, could this be allergic disease or not? So age of onset is important. And then character, duration, frequency, and severity of symptoms extremely important, because the guidelines for both allergic rhinitis and asthma are really based on frequency and severity of symptoms. So you need to really define that. Then you want to know if the symptoms are localized versus, are they single organ or are they multi-organ? So do they affect only one organ system, like the eyes, which would be allergic conjunctivitis? Or do they also affect the nose, which would be allergic rhinitis? Do they also affect the lungs, which would be asthma? So you need to know localized versus systemic. You want to know, again, the frequency and severity of symptoms, because that determines how aggressively you treat allergic rhinitis and asthma. And then you want to establish a temporal relationship. So when we're talking about allergic diseases, these are IgE-mediated disorders. When do the symptoms occur? If they only occur during certain times of the year, it could be seasonal. This could be from pollen. But if they occur throughout the year, then you're probably talking about a perennial allergen, dust mite, cockroach, mold, and pets. So these are some of the things that you need to be thinking about even before you do any investigations, because you want to have an idea of what's driving the disease. Speaking about triggers, so allergens can be a trigger, but also non-allergens can also be triggered. Tobacco smoke, irritants, weather changes, those can also cause symptoms that have nothing to do with allergies. So you want to be very attentive to that. You want to inquire about previous medications and the response to symptoms. Did the medications help? Did it not help? And then you want to have an assessment of impact of disease on quality of life. Is it affecting the school performance? Is it affecting work performance? Is it affecting activities of daily living? Is it affecting sleep? Again, because depending on the impact on quality of life, that will determine how aggressively you treat these patients, whether you put the patient on immunotherapy or not. And then you want to know about previous investigations, what was done so far, because certainly you don't want to repeat unnecessary investigations. So, was the patient already skin tested? Did they have sinus x-ray, or did they have a CT scan? Did they have previous lung functions? So these are all things you want to inquire about. And then environmental history is important. Is anyone smoking? So think about cigarette smoke. In India, also think about things like BD. You also want to know about cannabis smoke. You want to know about mosquito coils, which can also can contribute to asthma problems. Pets, outdoor pets, indoor pets. Fire. Is there a fireplace? Is there wood burning stove? What is the occupation of the patient? And then go back in time and take a birth history. Was it a vaginal delivery versus C-section? We know that patients born through C-sections are increased risk for atopic diseases. Was it preterm versus, full term versus preterm? Again, we know that preterm births have increased risk for asthma. They're also increased risk for airway remodeling. Was there any in utero exposure of smoke during pregnancy? Was the child breastfed or not? During infancy, was the child exposed to frequent infections, including RSV? Again, these are all risk factors potentially for developing asthma. So these are things that you really want to inquire about. And then also important to take a detailed review of systems, but when I say detailed review systems, really, you really want to focus specifically on the skin. You want to focus on the eyes. You want to focus on the ears, nose, throat, respiratory symptoms, cardiac symptoms, and gastrointestinal symptoms. And then take a past medical history. And again, here you want to focus, on associated disease disorders. So focus on allergic rhinitis, asthma, chronic sinusitis, otitis media, any history of atopic dermatitis, any history of food allergies, oral allergy syndrome, reflux, eosinophilic esophagitis, urticaria. These are the main diseases that are associated with that we see in our field. So these are things that you want to inquire about. You want to ask about a past surgical history. You want to ask about medications, including over-the-counter medications, aspirin, NSAIDs, decongestants, and then take a family history. And when I say take a family history, we're talking about parents, so mother, father, and then siblings. Again, most atopic disorders are partly genetic, so that's why family history is very critical when you evaluate a patient. Now, let's focus on some disease-focused pearls. So what I just showed you was a general template, but especially when you inquire about allergic rhinitis, what are the things you want to pay attention to? So you really want to define what are the primary symptoms: sneezing, rhinorrhea, nasal congestion, itching, ocular symptoms. Also want to focus on the secondary symptoms. Is there any fatigue, headache, cognitive impairment, snoring, sleep disturbance, mood disturbance? You definitely want to know the age of onset. We know that typically allergic rhinitis begins early in life. If the onset of symptoms is late in life, especially if it's after age 30, then it's probably non-allergic in nature. Is there a response to oral antihistamines? Typically, with allergic rhinitis, there is mast cell degranulation, which results in histamine release. Typically, if you put a patient on oral antihistamines, the itching goes away, or at least it subsides. Whereas with non-allergic rhinitis, there is no histamine release because it's not mast cell driven. And so typically patients do not respond to oral antihistamines. So this is a very key question to ask: do oral antihistamines help or not? And then you really want to, define the severity of the rhinitis by asking, is it intermittent, or is it persistent? And again, to remind the audience, intermittent means symptoms of rhinitis less than 4 days a week or less than 4 weeks a year, whereas persistent is symptoms more than 4 days a week, more than 4 weeks a year. Mild means no interference with any activities and no bothersome symptoms. Whereas if you have one or more of the following, then it automatically becomes either moderate or severe. So if you have sleep disturbance, if you have impairment in school or work performance, impairment of daily activities, leisure and or sports activities, or any troublesome symptoms, that by definition, the rhinitis is either moderate or severe. And then associated conditions. So for allergic rhinitis, we know, for example, that up to 50% of patients have allergic conjunctivitis. So that will be itching, tearing, conjunctival edema, hyperemia, watery discharge, burning, photophobia. A large percentage may also have sinusitis, so nasal congestion, purulent rhinorrhea, facial or dental pain, cough, asthma. As I mentioned, up to 40% of patients, especially children with rhinitis, may have asthma. And so thinking about things like coughing, which is very specific in children. And in adults, you may have a combination of coughing, wheezing, chest tightness. Think about atopic dermatitis. We know that a large number of patients with atopic dermatitis also have allergic rhinitis. And typically, atopic dermatitis in children present with pruritic erythematous patches, papules. It affects the face, the scalp, extremities, trunk, and it spares the diaper areas. Whereas older children and adults typically may not have these pruritic patches, but they'll have thickening skin. They'll have increased skin markings. They may have excoriations, fibrotic papules. And so these are, again, the things that you want to inquire about. And then oral allergy syndrome. So oral allergy syndrome basically involves itching or mild swelling of the mouth and throat, following ingestion of certain raw fruits or vegetables or nuts, and that is due to cross-reactivity to the pollen. For example, if you are sensitized to birch pollen, and if you ingest fruits like apple or the pitted fruits like plum, peach, nectarine, your mouth can itch, and that is because of the protein in the fruit closely resembles the birch pollen allergy. The birch pollen, which is BET-V1, and so it can cause localized itching and swelling of the mouth. We sometimes see that in patients who are strongly allergic to pollen. In children, oftentimes allergic rhinitis is associated with eustachian tube dysfunction. So you see an increased incidence of acute otitis media, serous otitis media. In adults, oftentimes allergic rhinitis is associated with obstructive sleep apnea. So again, something you need to be thinking about. In children, oftentimes allergic rhinitis can cause malocclusion, so the teeth are crooked. And in adults, migraine headaches can also be associated with allergic rhinitis. So again, these are some of the things that you want to ask about when you evaluate a patient with primarily allergic rhinitis symptoms. And then it's also important, if possible, there are some patient-reported assessments that you can, in order to objectively assess severity and control. Typically, these are done in research studies, but certainly, in the clinical setting, you can also have patients fill out these scales. One of the measures is called Total Nasal Symptom Score, or TNSS, where we have patients evaluate, the severity of nasal congestion, sneezing, rhinorrhea, or nasal itch. So it's out of 3, so 0 to 3, and so they can say, either no symptoms would be 0, and 3 would be severe symptoms, and patients can rate, over the past week. Same thing with ocular symptoms. This is the Total Ocular Symptom Score, or TOSS, where we ask the patient during the last week, have they had any itching of the eyes, redness of the eyes, tearing of the eyes, swelling of the eyes? And again, it's assessed from 0 to 4 in this case. So 0 would be none of the time, 4 would be all the time. And so this gives you a little bit more objective measurement of how severe their symptoms are. And then typically when you start a patient on therapy, then you want to see, well, are their symptoms controlled? So this is what we call RCAT, Rhinitis Control Assessment Test. This is a validated questionnaire where we ask patients during the past week, how often have you had nasal congestion? How often do you sneeze? How often do you have watery eyes? To what extent did your nasal or other allergy symptoms interfere with sleep? How often did you avoid activities because of your allergies? And overall, how well are your nasal or other allergy symptoms controlled? And so, again, this is a patient self-assessment, and the score here ranges from 6 to 30. So the higher score indicates better control. So the higher the score, the better the rhinitis. So this is something I would encourage you, if you can, maybe this will, while the patients are waiting, give them this questionnaire. It will help you in the assessment. Moving on to asthma, what are the things you need to focus on? So again, the cardinal symptoms of asthma: wheezing, coughing, shortness of breath, chest tightness. Keep in mind, however, that children may present differently. So in children, it may be just fatigue, irritability, their chest hurting. They may be avoiding activities. In infants, it may be difficulty eating, grunting during sucking of milk. We know that the cough in asthma is usually worse at night and after exercise. So that's important, to inquire about, when is the cough worse. And then when you talk about wheezing, it's important to define what is wheezing. So wheezing is predominantly expiratory. If the sound is predominantly inspiratory, then you really need to be thinking about upper airway obstruction. Okay, so this would be stridor. This would not be wheezing. So thinking about what are the causes of stridor. It could be from obstruction, upper airway obstruction from laryngotracheal malacia. It could be vocal cord dysfunction. It could be croup. So again, very important to clarify what exactly is wheezing versus stridor. As you can see, there are many mimickers of asthma. So mimickers of wheezing would be vocal cord dysfunction, foreign body aspiration, tumors, tracheobronchial malacia, bronchiectasis, bronchiolitis, cardiac. So these are all things you need to be thinking about in differential diagnosis. What are the mimickers of cough? Well, it could be chronic sinusitis, it could be reflux, it could be ACE inhibitor, it could be eosinophilic bronchitis, it could be simply post-viral cough, it could be pertussis, and especially in the case of India, you need to be thinking about tuberculosis. For dyspnea, a lot of things can cause dyspnea: COPD, heart failure, PE, sarcoidosis, obesity, even just simply deconditioning. So these are all things, again, in the differential diagnosis you need to be thinking about, and not simply assume that it's asthma. And then oftentimes you also have to be thinking about coexisting conditions. So chronic sinusitis, reflux, obesity, all of these conditions can make the asthma control worse. And these things can coexist with asthma. So you really want to inquire about these things. Respiratory symptoms triggered by exercise, cold air, and air allergens are highly suggestive of asthma, whereas just having a viral upper or lower respiratory tract infection, may not necessarily mean the patient has asthma, because anyone, even normal people, when they catch infection, sometimes they can transiently have respiratory symptoms that can mimic asthma. So you have to be a little bit careful. When you take a history. We also know that non-selective beta blockers can also trigger asthma symptoms. So when you have a patient and you know that they're on a non-selective beta blocker, that can also be a trigger. In terms of exercise, and this is something I want to clarify, when we know that the exercise is a trigger for asthma in about 80% of patients. When does this occur? So exercise-induced symptoms typically begin 5 to 15 minutes after exercise, not during exercise. And this is a very important point, because think about it, when you exercise, your body actually releases catecholamines, such as dopamine, epinephrine, norepinephrine, which cause bronchodilation. And so typically during exercise, that's not when you have symptoms. It is after exercise, after the catecholamines wash out. Typically, symptoms begin 5 to 15 minutes after you stop exercising, and then they resolve, with rest within 30 to 60 minutes. So when you ask about exercise-induced symptoms, it's important to ask what happens after you stop exercising, not during exercise. The other thing that's important to ask about is aspirin-exacerbated respiratory symptoms. So about 15% of patients with asthma have what we call aspirin-exacerbated respiratory disease. So when they take aspirin, or if they take a COX-1 NSAIDs, they will have asthma symptoms, typically within 30 minutes to 2 hours of taking the aspirin or NSAID. And so this is something, again, you want to inquire about. What happens when you take aspirin? What happens when you take ibuprofen, for example? Other potential triggers, so sulfites. Sulfites are found in shrimp, dried fruit, dried potatoes, beer, wine. In some patients, sulfites can also be a trigger of asthma. So this is something you want to also inquire about. Family history, so a strong family history of asthma, or history of allergic rhinitis, or personal history of atopy. So if the child or if the adult previously had atopic dermatitis or allergic rhinitis or allergic conjunctivitis, then that will favor diagnosis of asthma. In terms of environmental things, you want to ask about home exposures, so pets, so cats, dogs, birds. You want to ask about carpets, drapes, because those are reservoirs for dust mites. You want to ask about water damage, visible mildew, dampness, musty basement, because that can be a sign of mold exposure. Also want to ask about either rodent or cockroach infestations, because we know that mice and cockroach can certainly cause asthma exacerbation. So these are all things that you really need to inquire about when you see a patient with asthma. Now, in terms of what is the probability, so even before you do any tests, ask them, how do they respond? We know that if patient does not respond to bronchodilator or corticosteroids, then it's probably not asthma. If the onset of symptoms occurs after age 50, it's probably not asthma. It's probably, thinking about cardiovascular disease, thinking about other primary causes. It could be PE, it could be pneumothorax. I mean, it could be, it could be a tumor, it could be tuberculosis. So typically symptoms after age 50 is probably not asthma. Certainly if they're having chest pain, if they're having lightheadedness, if they're fainting, or if they're having palpitations, it's probably not asthma. And then in any patient who has a significant smoking history, so 20+ pack year smoking history, you need to be thinking about COPD rather than asthma. In those patients who have a established diagnosis of asthma, then you really need to assess their control, their level of control. One of the easy things that I think that can accomplish this is what we call the asthma control test. This is a validated questionnaire. There's one for adults and there's one for children. This is the one for adults. So it's called the asthma control test, or ACT. This is for any patient 12 years and older with asthma. It's basically 5 questions where we're asking, in the past 4 weeks, the patient does a self-assessment of their control. And basically, this is a score out of 25. And any patient who has a score of 19 or below means their asthma is not adequately controlled. So this is something I would highly encourage you to print out and give every patient who has asthma, who is 12 years and older. And then for your children less than 12, there is what we call a childhood asthma control test, where the first 4 questions are filled out by the parent. I'm sorry, the first 4 questions are filled out by the child, but read by the parent, and then the last 3 questions are filled out by the parent. And again, the score, any score 19 or less, is indicative of poor asthma control. So these are both non-proprietary. You download. They're available in multiple languages, including Hindi, and all of the different state languages. So this is something I would encourage you to give out in your asthmatic patients. If you are so inclined, there's another questionnaire, a little bit longer, but this is called Asthma Control Questionnaire, also known as ACQ. This is a little bit more detailed, but it's more used in a research setting. But again, this is a patient-reported outcome measure. It gives you a little bit more objective assessment of their level of asthma control. All right, so I'm going to switch gears now. So we talked about history, which I think, again, is very important. History is extremely critical. And I would encourage you, before you do any test, where you do a skin test or a blood test, make sure you take the appropriate time to get a good history. Don't jump to skin tests, don't jump to blood tests, because oftentimes, the results of these tests can bias you. So the diagnosis of allergy is predominantly a clinical diagnosis, whereas the tests are only ancillary. They may support a diagnosis, but they're not diagnostic in themselves. All right, so that being said, we'll talk now about in vitro blood tests in the assessment of airway allergy. And there's a lot of misconceptions around this. So the first thing is blood eosinophils. We know that as a general rule, patients with atopic disease, whether it's allergic rhinitis, allergic conjunctivitis, atopic dermatitis, asthma, patients with atopic disease have a high blood eosinophil level, but it is not an absolute must, because we also see patients with severe atopic disease who don't have an elevated blood eosinophil level. We also know that eosinophilia is non-specific. It can be caused by numerous other causes, numerous other conditions, including infections, specifically parasitic infections, which are very common in India. They can be caused by immunodeficiencies, inflammatory disorders, neoplastic conditions such as lymphoma, leukemia. So measuring the blood eosinophil level per se is not an appropriate screening test for atopy. That being said, it may be useful biomarker in eosinophilic asthma. And we know that in Western countries, patients who have blood eosinophil levels greater than 300 per microliter are at increased risk for future asthma exacerbations. So this is something that, at least in the West, we tend to measure. It's also something that for the biologics, if you want to use an anti-IL-5, for example, napulizumab or benralizumab, then you want to see an eosinophil level at least above 300 per microliters. But this is in Western countries. This may not necessarily apply to India, where generally eosinophil levels are probably higher due to the high parasitic load. As I mentioned, there are many other reasons besides atopic disease that can cause eosinophilia. So it could be primary hypereosinophilia. Think about myeloid and stem cell neoplasms. Think about myelodysplastic syndrome, systemic mastocytosis. So this is what we call primary hypereosinophilia. Other causes, infections, especially parasitic infections, fungal infections, ABPA can cause elevated eosinophil levels. Certain medications, antibiotics, NSAIDs. Think about gastrointestinal disease, eosinophilic ulceritis, inflammatory bowel disease. Certain immunodeficiencies like Job's syndrome, Wiskett-Aldrich syndrome can also cause elevated eosinophils. Certain rheumatological conditions like lupus, and then things like adrenal insufficiency can cause elevated eosinophil levels. So the main message here is just because the eosinophil level is high doesn't necessarily mean that it's an atopic due to atopy. So you need to be cognizant of that. The second thing that we sometimes I think is misused is total IgE. So patients with atopy, especially atopic dermatitis, often have high total serum IgE levels. But again, you can see severe atopic disease even in patients with normal total IgE levels. So IgE level itself is not really a good screening tool. Many other causes can cause elevated serum IgE levels, including infections, immunodeficiencies, inflammatory diseases, cancers. And again, in countries like India and developing countries, parasitic infection is probably the most common cause for an elevated IgE level. And so definitely total IgE by itself is not an appropriate screening test for atopy. However, it may be helpful in ABPA. So if you have a very high IgE level, that is one of the criteria for ABPA. So you need to think about it. And if IgE level is also very high, you may want to screen for infection. We also use total IgE level for dosing purposes. So, to calculate the appropriate dose in patients when you're using omalizumab in patients with moderate to severe allergic asthma. So the dosing is based on body weight and total IgE level. So this is where getting an IgE level may be appropriate. Also, patients with chronic rhinosinusitis with nasal polyps, for which we use omalizumab. Again, it's based, the dosing of omalizumab is based on body weight and total IgE level. So this may be appropriate in this context. Here's again differential of elevated serum IgE levels. So different infections, especially parasitic infections, can cause high IgE levels. Immunodeficiencies, including Job's syndrome, that's probably the classic, will cause a very high IgE level. Certain inflammatory diseases, certain neoplasms such as Hodgkin's lymphoma, and then you have various other diseases, and also drugs can also cause elevated IgE. So again, this is part of the differential. Now, let's talk about allergen-specific IgE. Now, allergens, when we talk about allergens, we're talking about proteins. So these are proteins derived from plants, animals, fungi, insects, and microorganisms. And we do have immunoassays. There are immunoassays available for environmental allergens, for foods, for insect venoms, for latex, and certain occupational allergens. And in terms of how accurate these allergen-specific IgEs immunoassays are, they are fairly accurate. Not as accurate as skin testing, but certainly, and the sensitivity and specificity can vary with the system used and also the quality of the allergen used. But overall sensitivity is about between 60 and 95%, and the overall specificity is between 30 to 95%. Now, in terms of the different immunoassays, ImmunoCAP is considered the gold standard. It has a higher sensitivity and specificity compared to some of the other immunoassays, but still not quite as high as skin testing. So in comparison, skin tests have both high sensitivity and specificity, over 85%, especially if you start also doing intradermal tests. And in subsequent lectures, we'll talk about the differences between skin prick test as well as intradermal tests. But these are definitely more have a much higher sensitivity, especially when you're using standardized inhalant extracts with high potency. So how does ImmunoCAP work? For those of you who don't know, so basically it's considered that if you are to do an immunoassay, I would recommend ImmunoCAP. It's considered the gold standard for both environmental and food allergens. Basically, you are taking blood you're taking serum from the patient, and it really, per test, it only requires about 40 microliters of serum. And the assay is what we call a sandwich fluorescent enzyme assay. So basically what happens is you have specific allergens. Those specific allergens are bound to a capsulated hydrophilic cellulose polymer. So these are different allergens over here on this cellulose polymer. And then what we do is we mix the patient's serum. So the patient's serum is mixed with antigen-bound substrate, which allows antigen-specific IgE to bind to the antigen. Okay, and then what happens is that then you form IgE antigen complexes, and then you add a fluorogenic material, which then binds, to the IgE antibody complex right here. And then so this kind of lights up. This is what we call a secondary fluorescent secondary immune complex. And then using a fluorometer, the fluorescence is red. And so the higher the fluorescence level, the greater the amount of allergen-specific IgE in the serum. So it gives you an approximation of how much IgE against that particular allergen there is in the serum based on how much fluorogenicity there is. And so the way that ImmunoCAP is interpreted, so a positive test means you have a presence of IgE to a specific allergen. And again, very important to reiterate that this does not equate to allergy. When you have positive, a positive in vitro test, all you are demonstrating is that there is allergen-specific IgE to that particular allergen. So the patient is basically sensitized to that allergen. It does not tell you whether the patient will have a clinical reaction to the allergen or not. Okay, it just tells you if the patient is sensitized. And so being sensitized alone is not sufficient to make a diagnosis of allergy. That's why clinical history is very important, because you can have individuals who are highly sensitized to an allergen but not have any clinical symptoms whatsoever upon exposure. This is whether it's for inhalant allergen or for a food. So please do not confuse sensitization with allergy. So allergy is a clinical diagnosis where sensitization is based on a positive in vitro blood test or based on a positive skin prick test. And so the definitive diagnosis of allergy requires both sensitization and a positive clinical history. Now, in terms of how you interpret this immunocap, so the likelihood that positive result will correlate with clinical reactivity is really influenced by two things: by the degree of positivity to the allergen question, and then as well as the patient's clinical history. So that's why, again, it's very important that you go back and ask, well, what happened? Let's say if the test is positive with cat, so you go back and ask the patient, well, what happens when you're on cat? If the patient says nothing happens, well, then that's probably not relevant. Or if the patient says, well, I don't have a cat at home, well, then just because you're sensitized to cat doesn't mean that it's clinically relevant. So again, you have to pair up results of a test, whether it's a skin test or in vitro test, with actual clinical history. Now, in this immunocap assay, the typical threshold for positivity is greater than 0.35 kilo international units per liter. That's the minimal cutoff. Generally, the way the results are graded, they're graded in classes 1 through 6, and these are based upon arbitrary divisions on a reference curve. What is considered clinically relevant is generally when you have class 3 reactivities, which would be greater than 3.5 kilo international per liter. And so this is an example here. So even though the assay will detect anything above 0.35, which is over here, those low levels of sensitization are probably not clinically relevant. What we consider clinically relevant are class 3 or greater. So at least 3.5 kilo international units per liter or greater. So the higher the IgE antibody concentration, the greater the chance that it is clinically relevant. Now, again, this also depends on other things, other factors. Age depends on degree of atopy. Is a patient atopic in general or not? Allergen load depends also on the type of the allergen, the clinical history, and other triggering factors. But in general, the higher the level of sensitization, the more likelihood that the patient will have a clinical response to that allergen. Could there be false positive? Yes. So false, because this is in vitro blood test, and we're only measuring free IgE. So this is not an in vivo test like a skin test where we're measuring IgE to bound to mast cells. We're simply measuring the presence of free IgE in the serum. If you have a very high total IgE level, then you can have non-specific binding. So a high total IgE level can cause a false positive in immunocap test. What do I mean by high IgE level? Typically, if it's over 1,000, 1,000, 2,000, then usually you may have a low level of non-specific binding, resulting in false positives. Can you have false negatives? Yes. So a negative result in the setting of a strong clinical history, does not exclude allergy. So in this situation, you really need to skin test or simply redo the in vitro blood test. So again, allergy history is extremely important in this setting. What are the advantages of in vitro blood tests compared to skin testing? Well, certainly in India, you have limitations on how many providers know how to do skin testing. So in this regard, in vitro tests are maybe more accessible, more widely available. Also, they're unaffected by the presence of antihistamines or other interfering medications. Those don't need to be stopped because you're simply measuring free IgE in the serum. You're not measuring, this is not an in vivo test looking at mast cell degranulation, so antihistamines don't need to be discontinued. It's useful in patients with severe anaphylaxis, in whom skin testing may carry a high degree of risk. And it's also helpful in patients who have skin conditions that may preclude skin testing. For example, a patient with severe dermatographia, a patient with severe atopic dermatitis. In that situation, doing skin testing may not be very practical because they'll give you false positives. Also, we know that in infants, for example, infants less than 12 months, generally their mast cells are not fully reactive on the skin. So in vitro blood tests, may be actually better in this situation. Whereas, immunoassays have been shown to be fairly accurate even as young as age 6 weeks of age. And it can actually be performed on capillary blood. You don't even need venous blood. Just on capillary blood, you can do an immunoassay. And then this I mentioned before, but individuals who have experienced recent anaphylaxis may have falsely negative skin tests for several weeks due to mast cell depletion. So if you have a patient who recently had anaphylaxis, skin tests may not be as reliable because they've already depleted their mast cells of histamine. And so you may have false negative skin tests, in which case the in vitro blood test would be a better test. So just to summarize, again, I think it's very important to reiterate that obtaining a good clinical history is crucial to making accurate diagnosis for allergic airway disease, whether it's upper airway or lower airway. Patient's clinical history really informs the selection of the appropriate diagnostic tests, not vice versa. So take some time to really focus on clinical history and make sure that you're not influenced by any diagnostic tests. First, take a clinical history and then do the testing, not in the reverse order. And then also keep in mind that treatment guidelines for both allergic rhinitis and asthma are based primarily on severity and frequency of symptoms and impact on quality of life. So, things like spirometry, yes, they're good ancillary tests, or external oxide measurement, they're good ancillary tests, but the bottom line is the way we treat allergic rhinitis, the way we treat asthma, again, is mainly based on history. It's based on frequency and severity of symptoms. So that can only be obtained by taking a good clinical history. And then the last point I want to make is you really want to take the time to ask questions beyond the presenting complaint, or else you will miss critical information. So, and what I mean by history is, so you want to include environmental history, you want to do a good review of systems, you want to look at current medications, past medical history, family history, and you want to have a system. So you want to be systematic in your history-taking approach. You want to know why you're asking questions, what questions to ask, why you're asking these questions, and you want to go through in your mind, you want a differential diagnosis as you interact with the patient. In vitro blood tests, can play an ancillary role in the diagnosis of airway allergy, but one must know how to interpret the results. So that's really key here. And so with that, I'm going to invite the panelists maybe to join me, and also invite the audience. If you have any questions, please address it to us. We'll try to answer as many questions as we can.
Thank you very much, Dr. Vinay Mehta, for this wonderful deliberation. And I'm requesting all the delegates who are there, please post your questions. We'll take all those questions after this panel discussion. And at the meantime, I also request all the delegates, you will again get the access of post-test. So please click on the link of the post-test and fill that Google form. Please try to fill all those questions because those responses will be taken. And now it is a real honor for me to invite all the distinguished panelists with us today, starting from welcoming Professor Nandini Chatterjee. Madam needs no introduction, but she is currently professor at the Department of Medicine at SSKM Hospital and IPGMER. So welcome, madam. Also, we have with us Professor Indronil Haldar. He also needs no introduction, especially who are following Indian Chess Society, ICS. So he is currently professor and head at the Department of Pulmonary Medicine at College of University of Medicine, COM, Jawaharlal Nehru Medical College and Hospital at Kalyani. So welcome, sir. We are also really proud to have with us Dr. Balachandra BV. He is again a very renowned allergist and pediatrician at Manipal Hospital, Bangalore. And he is also the director of the course that is empowering or building capacity among the chest physicians, pediatrician in the field of allergy, that is allergy asthma specialist course. So welcome, sir. And we also have with us today Dr. Taha Qureshi. Dr. Taha Qureshi is also a well-known immunologist and allergist at SKIMS Hospital at Srinagar from Jammu and Kashmir. So welcome you, sir, again. And also may I request Dr. Binoy Mehta, sir, to stay with us for this panel discussion. We will have some question for you also, sir, and we'll take the delegates question at the end of this panel discussion. So I am asking all the delegates, if you have any questions, any queries, please post in the chat box so that we can take those. So my first question is to Dr. Balachandra BV. Sir, as already Dr. Binoy Mehta had discussed this elaboratively. So what specific questions should be asked during patient history taking to aid in the accurate diagnosis of airway allergies? So if you can summarize those points for us.
Yeah, thank you, Dr. Shambhu, for the opportunity. And I think most of the things have been answered by Dr. Vinay Mehta, and Sir has put it across in a more methodical way, and also Sir has summarized it. So I would probably reiterate that and probably add on to the clinical scenario how Indian practice works. So basically, a patient comes to a doctor, he might have allergy, he might not have allergy, or he might walk into a pediatrician or a pulmonologist office with an allergic symptoms or with a general symptoms, non-allergic symptoms. So first and foremost things when we are talking about airway allergies, we need to ask few details to differentiate whether it is an allergic condition or it's a non-allergic condition. So we'll start from there, and once we know that it is an allergic diseases, we would probably ask few set of questionnaires to know that multiple aspects or domains of the allergic diseases. So one thing which I want to tell is, in India, we generally are very, very busy in our practice, and allergy requires a more detailed time and particular set of questions so that the justification is done for the patient. So if it is hurried up, or if it is taken in like a regular case or regular in any infection case or anything, we might end up missing out many details, and that results in an impact in the treatment of the patient. So what all the questions what we need to ask, or what all the components what we need to include is more detailed diseases about the particular allergic disease in focus, and also to know the disease severity. So that's a one set of questions which you will ask. I would also suggest that whoever is practicing allergy, they need to have a good allergy assistant with a set of papers which is already questions are printed. This will help them a lot, help a doctor a lot to save his time as well as get the good complete information. So know about the disease and its severity, the particular type of questions which you can ask by which you know that the disease, whatever the causative allergen, can be identified at the level of history itself. In fact, the investigation are only going to help us to confirm it, but many a times without investigation, we should be able to nearer to the diagnosis of allergy. We should also know that how much of these allergic diseases are impacting the patient's life, day-to-day life, is activity, is sleep, everything. We should ask questions specifically for comorbid conditions which are associated. If comorbid conditions are left out, our treatment, our diagnosis is incomplete. Okay. So all other atopic conditions which are present needs to be confirmed. Similarly, family history, personal history, past history, environmental history, and what all investigations they have done, and what all the drugs they have been taking, how they have been taking, all these details are required. I would just put one important points in each one because it's already discussed a lot. Whenever you start taking an history, the first few questions are, say a patient might come with us saying that I'm having a cold or I'm having a cough. The first question is, what is the frequency, how long it has been present, and what is the severity, diurnal variation, seasonal variation, how is the patient in the interval period. These 5-6 questions will tell us whether it is an allergy or it is non-allergy. If it is a short, looking like any other viral infection or any other thing, then we might focus on a different aspect. Generally, doctors who are practicing both. So whenever you look into thinking of it's an allergy, please classify and ask the questions in the patient's language. Like, it is a leak, whether it is a leaking nose or a blocked nose, or it's a snoring is present, or it's a sneezing, rubbing of the nose, high itching, high redness. We need to ask questions in a patient's language. If we start using questions in a medical terms, we might end up missing out many of the patients. Similarly, when it comes to cough, many people will tell it as cough, some people will tell it as a phlegm. So we need to ask the specific questions in respect to that. So whenever you want to know the causative allergens, the timing of the symptoms will give us a lot of information. Early morning symptoms, in the night symptoms, when the patient wakes up with rubbing his nose, most of the times it is a dust mite which is causing the allergy, and only test is going to confirm. Especially if it is a perennial allergen was a seasonal allergen, we know what we are dealing with that. If it is an indoor allergen versus an outdoor allergen, then we know where we are targeting about it. Whether the symptoms are present in the house or in the office or where it is present, we can know that where the symptoms are present. Unfortunately, we don't have a great pollination calendar, but still whatever the details we have about the pollen calendars in India, which is done in probably 1990s, still to a large extent it holds good, and those information can be utilized for us. So as again I told, ask about the patient's quality of life, sleep, work, and also psychosocial impact, which sir has emphasized on it. Ask about comorbid conditions like sinusitis or obstructive sleep apnea, GERD. So family history is very important. Please ask about indoor history, like it can be an incense stick which is used in our country regularly day in and day out, and mosquito coil, carpets being present, molds being present. So again, what all the investigation which has been done, what medications it has been used, how they are using the medication, whether they are using it in a right way or wrong way, any other antihypertensives, diabetes which is present. So whole lot what I want to tell is, sir has already emphasized, please make a structure in your practice. Either use a software so that your data is collected and it can become a research article, or have a series of printed papers where you can ask a specific questions, and then your consultant can, probably an assistant asks the questions and your consultant summarizes it and then gets to know what's happening with the patient. But whatever said and done, doing an incomplete history is nothing but doing an incomplete job. And history is the most important diagnostic capability what we have. The allergic tests what we have is comes always secondary. Thank you, Dr. Shambhu.
Thank you, sir. Thank you. So one of the very key message from what sir has taught us, that if we have someone like assistant, technical assistant, just before entering into our chamber, if we can screen them through some predefined questionnaire, so that could be easier for us, especially when we are seeing a lot of patient in a short duration of time. So thank you, sir. And now continuing with this time constraint, and the doctor patient conversation time is also much lesser. and due to our patient load. So may I ask Professor Haldar sir, Professor Indranil Haldar sir, that how you can describe the key physical examination techniques that are very critical in diagnosing airway allergies?
So thank you, Shambhu, for giving me the invitation. That's the onset. And after a good history, as you already told, that the most important crack in the diagnosis of allergic disorder is the history. Now come the physical examination. When it comes to physical examination of airway allergy, we mean two airway allergens, the allergic rhinitis and the asthma. So when it comes to allergic rhinitis, we have to assess the outward signs, which include the nose, the ears, the sinuses, the posterior oropharynx, also the chest, that should be there. So if you see that is persistent mouth breathing, or there is rubbing of the nose, or if you see a transverse crease of the nose, frequent sniffing or throat clearing, this allergic sinus is another very important diagnostic aid, which is the dark circle under the eyes, and due to nasal congestion. People label it because of, say, nighttime awakening, and because they are awake for the long time at night, but it is because of the allergic sinus. Now comes the clinical examination of the nose. You can see swelling of the nasal mucosa, which may be pale. There may be thin secretion. If you have an internal endoscopic examination, then you can see the nasal ulcerations or the septal deviation, if there is any there, or nasal polyp. Here, basically, it is not that much of examine, but yes, if you can see the tympanic membrane on valsalva, it may be helpful. Whether there is any block Eastern tube can be seen. But a very important examination, which you sometimes miss, is the sinus examination, palpation of the sinus, evidence of tenderness. The posterior oropharynx can also be examined for postnasal drip or accumulation, mucus accumulation in the back. And definitely the examination of the chest is included in also in the allergic rhinitis to see concomitant asthma or not. But when it comes to the another airway disease, asthma, it is very important that we examine these patients, and the examination depends upon the severity of the asthma. So whereas in the mild variety, you may not get anything, but yes, if you definitely get a rhonchi in the chest or a prolonged expiration, which may clinch towards a obstructive airway disease. But in very severe disease, you may get a silent chest, the pulsus paradoxus, and the other features of very severe acute asthma may be there. So definitely, when it comes to asthma, you may get normal, but rhonchi may be helpful. In severe asthma, there are other clinical findings. So these are the all clinical things which may clinch you to some of the airway allergic diseases, and you should be aware, and proper examination is very important.
Thank you, sir. Thank you very much. So now I move towards Dr. Qureshi. So I know that Dr. Qureshi had been working with lots of drug allergy cases too. So may I ask Dr. Qureshi about your approach towards the history taking when you were seeing your drug allergy patients, and especially what are the tests you were then performing depending on the history? Over to Dr. Qureshi.
Thank you. Thank you so much, Dr. Shambhu, for giving me this opportunity and to be a part of this elite panel. Thank you so much. Before going to drug allergies, I just want to share one anecdote with you, which was a real-time anecdote for me regarding this. That actually represents the importance of history taking in airway allergies. We had this 22-year-old female who was a typical allergic rhinitis. That whole scenario she fitted in. We did the skin prick testing, and her dust mite came out to be 5+. If we take that Scandinavian scale, there was actually a big wheel which was almost thrice the size of the histamine, and then it had a pseudopodia as well. And then obviously everybody does the way everybody does. We took a second history after doing her SPT, and what we found out, the history of her symptoms was just 6 months or so. She was 22 years old that time, but history of her symptoms was 6 months only, and the severity was quite high, but didn't fit into that typical early morning symptoms, typical that indoor symptoms only and all that. Somehow not very convincing, not very much collaborating with this this being allergic to house dust mite. But then obviously since the skin this testing revealed big wheal, pseudopodium, huge erythema as well. So we were more inclined to start her for an allergy immunotherapy. But before that, what happened, we thought let's wait for a week or so, ask the patient to come for follow-up. In the meantime, my Bala sir talked about assistant. My assistant, she was very Nusrat, she was very clever. She spoke to the attendant of the patient. We took to the history of many things, but there was nothing significant. Mother of the this girl revealed that this girl has taken a pet turtle from some time, pet tortoise. From 8 months or 9 months or something like that from her college. Somebody had gifted it to her, and after the pet turtles, around 3 months or so, patient had developed symptoms. It was somehow correlating with that time. Then I tried to Google. Turtle is not very allergenic organism, allergenic animal. Then this pet, what we try to find out, we thinking of what it could be. Then I asked her what food do you feed this turtle with? They said we feed this turtle with the fish food. And then she got the label of this food next day. And when we found the label of that food, we tried to find out the contents on the Google again, and it revealed that it contained shrimp, lobster, and many other these sea-based foods. And that's actually the lead. Actually, the lead was there only. Most it was the food would be given in the form of powder, and this powder likely got up into the nose of the patient, and obviously this is strong cross-reactivity with dust mite as well. That's why we got this huge sensitization on doing her skin testing with dust mite only. We did not test her for seafoods because seafoods is not something what is eaten at our place. So we didn't do that that time. Then later on, obviously, the first thing we asked this patient, to do away with the turtle for some time and the food as well. And within 3 months of time, the patient was off symptoms. The patient was absolutely fine the way she was 8 or 9 months back. So in this particular case, this is one case where this history taking made a huge difference. We could have gone in absolutely wrong way had we gone with the results of the skin testing. So this was regarding airway allergies. Rest, Bala sir, obviously Vinay sir already have explained what is the importance of this history taking when it comes to airway allergies. But as regards drug allergies, again, history has that at the cornerstone of management is the history, because you got to ask the whole thing from the patient. I mean, first, when did this occur? After how much of time of the intake of the drug this occurred? Then did you take some more drug? Temporal relationship is the most important part to find out whether it was which type of allergy it was an IgE mediated or a non-IgE mediated, because usually the IgE mediated happens within the first hour of reaction, first hour of the intake of the drug. Then obviously in the history, then you see has the patient taken any other drug during that point of time associated. There's a questionnaire, full-fledged questionnaire, which contains then what other drugs were given concomitantly, and the having some knowledge of the basic that tendency of the drug to cause which type of reaction, one can make out what the patient could have been allergic to. And after this history only, then you can decide, go ahead with further investigations. In case of drug allergy, most of the times it's not the in vitro testing. Many times not even the skin testing. It's ultimately the graded drug challenge, which tells you exactly is the patient really allergic to the drug or it's not allergic to the drug. Be it type 1, be it type 4 reaction, you go to the graded drug challenge, except for when it's contraindicated. Like having an organ-based allergic reaction. In that case, you look for an alternative drug.
Thank you. Thank you, Dr. Qureshi. Actually, you had emphasized the case, what you had discussed. That actually emphasized the importance of clinical history, which can actually complement and inform the whole diagnostic process. And we also talk about retake of history after having some diagnostic test results, like especially the skin prick test. We need to retake the clinical history, and that could help us in decision making, especially when we are considering allergen immunotherapy.
Just
So-
one more thing, Dr. Shambhu, can I have 2 more minutes?
Sure.
Yeah. Which I forgot to tell you that there was this drug allergy case. I mean, just emphasizing the history taking. There was a young female who was admitted in our colorectal surgery ward. She was admitted as a case of colorectal, rectal prolapse in that ward. On day 1, she had this rash throughout the body with some amount of shortness of breath. Soon after taking IV levofloxacin, next day she was shifted to the ward and to the main ward. Where for the first episode happened in the emergency ER room. Next episode happened in the ward itself. She had taken IV DNS, and immediately within 5 minutes she developed anaphylaxis. Then after an hour or so, she was given IV ringer lactate. Actually, they were preparing her for the surgery. For the correction of rectal prolapse. After giving this IV ringer lactate, again within 10 minutes, she developed anaphylaxis. So this is the stage when we were called to that ward as to why this is happening, because they wanted to operate the patient. And then once we took the history of this patient, she was typical that allergic rhinitis, rhinitis asthma, which had been ignored. At that point of time, we asked her, did anything more happen? She didn't reveal any previous allergy to any other drugs. Like she was taking that commonly used drugs like antibiotics, NSAIDs, and other drugs which are given PPIs, which are given in our setup, even over the counter. And it was kind of a scenario where it was a tough time for us to tell these what the patient could be allergic to. The surgeons were obviously they were keen to operate the patient because patient needed surgery. She was having rectal prolapse. Then we tried to take a meticulous history again. And the patient revealed that she had one more episode of shortness of breath and rash once her physical examination at the time of entry to the hospital was carried out, which included a rectal examination as well. So that's what struck this point in the history struck us something in our mind. What we did, we made the patient wait for another 4 weeks. And after 4 weeks, because that's that refractory period after anaphylaxis when you want to test somebody, during that 4 weeks, that histamine reserves are replenished. After 4 weeks, we did a skin prick test with latex in that patient. The latex came out to be positive. We did one more test those days. That latex had just come to India, latex specific IgE area. We did latex that was highly positive, something 9.4 or something was the value. And then we did a latex puddle test, the locally made latex allergen with that gloves. And that was again positive. So the examination of this patient at the entry point, which included a per rectal examination as well, with obviously we use the latex gloves, that probably had triggered that first episode of reaction in that patient. Later on, while using that tubing and other things, and while giving IV fluids and other things, it was not those ringer lactate and other things, because patient would otherwise tolerate every antibiotic, every other drug. So what we suggested these surgeons that you use a latex-free operating facility, whatever was possible. I mean, absolute latex-free operating this facility is very difficult in our setup. So that's what was being done with them, and some preoperative medication as well was given, and the patient was operated nicely after this period of 4 weeks. And there also, this history taking had an absolutely important role in deciding what is going to be the culprit. Both of these cases are case 1, tortoise case, as well as this latex case. We have published it. I can share it with you, Dr. Shambhu. You can share with the rest of the league.
Great. I think this is a very beautiful learning lessons. These 2 cases are really very helpful for us also to become actually a Sherlock Holmes while taking the history taking. So we should be Sherlock Holmes like features. Just a short comment from you, because nowadays, as I had asked you about the drug allergy, nowadays if we go through our hospitals, we'll see before giving antibiotics, still we are using that skin testing before giving any antibiotic. And sometimes in the bedhead tickets, it is mentioned like that injection something, and in bracket they mention after skin prick test, like that. So what is your comment on that, and especially on background of current guideline, what you will want?
Dr. Shambhu, I'm really glad you asked me and you gave me this more opportunity to talk about it. This is one of the common mistakes we do. writing after test dose, and then we do this skin test dosing, in a very wrong method. Skin test dosing is good for some drugs, especially beta-lactams. There are established guidelines for it, but there are 2-3 mistakes we make while doing this skin testing. One is using the wrong concentration of the drug for skin testing. Another is the method we do it. Then third is the quantity we use is usually wrong. I can talk about my setup. The first thing is the concentration. We always, whenever we do skin testing, we need to use the non-irritating concentration of the drug. For example, our ceftriaxone is there. In ceftriaxone, 1 gram is contained, 1,000, that means 1,000 milligram is contained in 10 ml solution, which actually comes with that, 1 ampule comes with that injection. So that becomes 100 milligram per ml. And once you skin test, you don't have to use 100 milligram per ml. The guidelines say, guidelines published by American Academy, European Academy, both, they say it is to be diluted 10 times. You have to make it 10 milligram per ml first. Then only it becomes a non-irritating concentration. Otherwise, it's an irritating concentration. And once you do testing with that irritating concentration, you can get a irritation in the skin, and that might lead us to have a false positive, I repeat, false positive result. So the concentration, correct concentration is to be used. Then the methodology of injecting has to be really good. It has to be an intradermal injection, not the subcutaneous. At our places, most places, that is being done. And for using a subcutaneous, doing an intradermal, all of your well-known allergists, we have to use, the needle is to be used anything beyond 27 gauge needle. We can even use an insulin syringe sometimes, or that tuberculin syringe needle. That gives an intradermal testing is to be done. So intracutaneous test, that's also known as you raise a bleb. You raise a bleb with that intracutaneous test. Once you raise that bleb, then mark the boundaries of that bleb. Then wait for 15 minutes. If that bleb, if that wheel with the intradermal test after 15 minutes extends beyond 4 mm to 5 mm, then only that test is supposed to be positive. This is true for the intradermal test. So there are these American and European guidelines. Both guidelines give concentrations for intradermal testing as well as concentrations for skin prick testing. So they need to be followed. That's actually to be done. And while doing this intradermal testing, one more thing is that we often use the wrong amount of drug when we inject it. The amount of drug to be injected is maximum is 0.05 ml. That means around 3 units of insulin syringe, not more than that. We often use much more than that, and that's what again gives false positive results. And the injection has to be intradermal, not subcutaneous. I can talk about my place, and I hope it's not being done other places also. And skin testing is to be done only for those drugs where it's being recommended. Not all classes of drugs like NSAIDs, like opioids, like quinolones, it's not to be done, because these drugs have an intrinsic this potential to for a histamine release within the skin. So again, their skin testing could be very, very misleading. It's not to be done with those many drugs. Usually, some drugs where these guidelines, beta-lactams are there, then in case of clarithromycin class, azithromycin class, you can do it. And a limited number of antibiotic class, rest, not of great value.
Thank you, Dr. Qureshi. May I ask the same question, and what is the practice in US to Dr. Mehta? Can you please elaborate this issue? Because I think this is a very challenging situation in our country. Many of our prescriptions, bedhead tickets contain that after writing the ceftriaxone, they mention after skin testing, you give ceftriaxone only. So what is your take?
So we don't routinely skin test. There has to be a reason, because if you blindly skin test, you may have. There are 2 issues here. Number one is there's only very few drugs to which you can actually skin test to. So beta-lactams, cephalosporins, local anesthetics, and that's beyond that. There's nothing else, because most drugs, it's the metabolite that causes a reaction, not the native form. With beta-lactams, you need there's actually 2 determinants you need. You need a major determinant, which is pre-pen, which is not available in India, unfortunately. And then penicillin G, which is minor determinant. So, so I think number one is the limitation is you need to have appropriate material to skin test, number one. Number two, again, it has to, go back to the history. Why are you skin testing? You don't want to do blindly skin test people if there's no reaction, because you'll confuse people. You'll confuse the patient, you'll confuse the physician. So as a general rule, we never there's no such thing as routine screening test. Same thing with foods. I think foods is another thing which I know in my experience in India, patients are routinely, blindly, they're tested for foods for no good reason. The false positive rate for foods is up to 60%. So if you blindly put on, if you blindly skin test to 100 foods, 60 of them will maybe falsely positive. So there has to be a reason. There has to be a reason. So same thing with venom immunotherapy. Sorry. So I'm saying with insect allergies. So 25% of the general population may have, if you do a skin test or if you do a plain blood test, they may be sensitized to honeybee, wasp, yellow jacket. It doesn't mean that they have an allergy. So the rule here is please do not, unless the patient has had true anaphylaxis or true high IG. That's the other thing. The utility of a skin prick test is only for immediate hypersensitivity reactions, meaning typically within 1 hour of the food ingestion or the drug injection or the insect sting. Within 1 hour, you develop urticaria, angioedema, wheezing, blood pressure drop. These are symptoms consistent with anaphylaxis. It has to occur within 1 hour. Then you suspect type 1 hypersensitivity reaction. And that is the only time you do skin testing. Most reactions to drugs are not IG mediated. They're not type 1 mediated. And so there's really no need to do skin test. And ultimately, more importantly, even if you do suspect type 1 hypersensitivity reaction, there's very limited drugs to which we can skin test. So penicillin, cephalosporin, and pretty much that's it. There's no good in vitro blood test either. I know that's something in India. Commonly, there's in vitro blood tests. None of those have been validated. So I would caution using those tests. Again, the main thing is please go back to your history. It seems very old-fashioned, but history, especially in the field of allergy immunology, is highly diagnostic, highly predictive, more so than any test you can order.
Thank you. Thank you very much, sir. So the take-home message from Dr. Qureshi and Dr. Mehta is like that. Without having the appropriate history, it is not worthy to do the skin testing. And especially if we do skin testing without proper history and it shows some positive result, there is a high possibility of that could be a false positive result, and that may cause some wrong label on the very common antibiotics, which may hamper our antibiotic stewardship program. And that is the most important issue in countries like us, where we are facing challenges like antimicrobial resistance. So thank you again, Dr. Qureshi and Dr. Mehta, for addressing this issue. Now, may I move to Professor Nandini Chatterjee, madam, because I want to discuss a very important case and want to ask madam's opinion, madam's approach to this particular case of a 30-year-old female with a known history of SLE. So she was suffering from SLE. Now present to the clinic with a new onset, widespread rash and fever. She mentions that she started taking a new antibiotic for a respiratory infection about a week ago. On examination, we find a symmetric erythematous rash on her torso and upper extremities. She appears systemically unwell. And her laboratory tests show elevated inflammatory markers, very high CRP level, and she has leukopenia. Now, considering the background of hypersensitivity reactions we had discussed in the last module, module 1, could this patient's symptoms be indicative of a drug-induced type 3 hypersensitivity reaction? And how would you differentiate it from lupus flare? Madam, please.
Thank you, Shambho, for inviting me to this August panel. We are dealing with SLE patients, and this is a very interesting question that you have asked, because if a patient of SLE who is prone to develop various types of rashes, which are close mimickers of drug rashes, so this situation we often face. Now, as Dr. Mehta, Dr. Bala, and Dr. Qureshi all have stressed, is that the importance of history and the temporal association between intake of the drug and the development of the sign. So that is the most important thing that we should focus on. As you have mentioned, that the patient has been taking some antibiotics because of a respiratory illness. So first we will ask if whether similar rashes had occurred before, and if this is the first time, when was she starting her antibiotic therapy, whether she's continuing it, and these rashes are increasing more in severity. However, this is one aspect of assessing her. Number two is that whatever be the history, we need to stop the antibiotic because we have some suspicion and see whether the rashes are going down or not. The third thing, which is very important, is that SLE is a multi-system disease, and it has, apart from skin manifestations, manifestations in other organs. So if you need to find out whether she has another SLE flare and not just a reaction to some antibiotic, we need to examine her from head to foot. We need to take history of all the other organ systems, and most common of it is the renal system. So we will be inquiring whether she's been having some reddish urine or not, whether her feet are swelling up recently, whether she's having a recurrence of fever, her joint pains have increased or not. But again, these are confounding factors because there may be some joint pains in association with a Arthur's type reaction. However, our clinical diagnosis is always an association of various types of history and clinical examination. So should I go on to how to assess about the investigations, or should I stop here?
Yes, sir. Yes, madam, you please. Please.
Okay. So apart from examination of skin, if we find that she indeed has tenderness in her joints, there is swelling of feet or periorbital puffiness, her blood pressure is on the increase, she has fever, or a general ill-being, as you have said, that she was looking unwell, systematic. So there we would be asking for certain investigations to look for disease flares. And it starts from the simple investigations like urine analysis and a complete blood count. So in the complete blood count, if we find a leukopenia, as you have mentioned, or there is a falling platelet count, so we may suspect that she is going into a disease flare. Urine analysis is another very important investigation, easily accessible in all smaller setups, where if you find RBCs or increased protein in the urine, so you think about something else, may not be the drug. So, and of course, in setups where a better investigations are available, we will go for the dsDNA level and the complement levels to assess her, means the whole ANA profile. But to remember, we start from history, the temporal profile with the drug. We stop the drug and see how she is faring, whether she is improving or not, or she's continuing to deteriorate, and then we go for the further work.
Thank you, madam. So actually, sometimes the issue is like that, as madam has already discussed beautifully about, we have to differentiate between the drug-induced disorder and the disorder itself. And when we talk about type 3 hypersensitivity reactions or any non-type 1 hypersensitivity reaction, the problem in diagnosis is the temporal relationship. It is sometimes maybe delayed by 6 weeks to 2 months also, the onset of symptoms and the stoppage of the drug. So it is very difficult to diagnose the non-type 1 drug allergy cases or drug hypersensitivity reactions. And for that, I think there is a possibility of doing LTT, that is lymphocyte transformation test, but it is not that much available in part of our country. Mostly it is research based tool what we have here. But I think if we can popularize this LTT process, along with obviously the patch test, then we could have more informations. As of now, what we have already emphasized by all our distinguished panelists is the history taking. If we have a proper history taking, that can help us to diagnose very closely. So now may I ask Professor Haldar sir, Professor Dr. Indranil Haldar, about, because you were seeing lots of asthma cases. So how do comorbid conditions like asthma and chronic rhinitis that can affect the management of airway allergies? And what are the important steps already you had mentioned during the history taking and clinical examination that also can help us to diagnose chronic rhinitis? But actually, how do you correlate these two, asthma and chronic rhinitis, in your practice?
So thank you, Sambo, again. So there are various conditions which include the rhinosinusitis, GERD, then psychological disturbances against chronic infections, even obstructive sleep apnea, OSA, may coexisting in patients with allergic diseases which include allergic rhinitis and asthma. So what happens? This comorbid condition may change the phenotype of the disease itself, or maybe a part of the pathophysiological process. So when I tell phenotyping, for example, you may be dealing with a patient of, say, allergic rhinitis or asthma with obesity. So asthma with smoking, or allergic rhinitis, aspirin intolerance, or it may be asthma with bronchopulmonary aspergillosis, as we call ABPA. So these are the something which we should take into account. So it may be part of the same pathophysiological process. For example, same airway, same disease, as we call allergic rhinitis and asthma. Until the allergic rhinitis is controlled, the asthma will not be controlled. Or if you are having allergic rhinitis, always do a spirometry at least, or take the history to find whether this patient is suffering from asthma or not. And another important, which is really underestimated, is obstructive sleep apnea. So allergic rhinitis itself may cause obstructive sleep apnea, but they may be coexisting obstructive sleep apnea, which may be because of the obesity also. So they act as a confounding factors in the diagnosis and also in the assessment of control of this asthma. So these are something which I probably think, because say, for example, I will take into single account allergic rhinitis. So 30% of patients of allergic rhinitis will have asthma, or about 70-80% of asthma will have allergic rhinitis. This is to be thought of, and because of the same airway and concept and unified airway concept, you have to think of it. GERD, again, what is the cause? Whether GERD is causing the asthma or the asthma medication is causing GERD should be taken into account. So these are something which should be taken from the history and relevant clinical investigations to find out the comorbid conditions, and unless the comorbid conditions are taken care of, control of the allergic disease may be really difficult.
Thank you, sir. Thank you. So you also place now the intranasal corticosteroids along with this inhalational corticosteroids that already had been taught by Gina. So in your treatment armamentarium, sir.
Yes, yes, please. Yeah, that's the thing.
Yes, yes. Thank you, sir. Thank you very much. So now, may I ask Dr. Valachandra, sir? So, as we are seeing many cases of airway allergies, at the same time, we need to consider the differential diagnosis also. So, how actually your clinical approach? Already you had discussed what are the key features to say this is an allergic disease. But again, to re-emphasize on differential diagnosis of airway allergies, what should be your approach, sir?
Thank you, Dr. Shambhu.
And at the same time, sir, I just want to be ask one question that has been in the chat box also, almost similar type of questions asked by one of our delegates in the very beginning. That so gustatory regarding I am seeing Dr. Povitro Banerjee is asking about vasomotor, gustatory rhinitis, cold air, all occupational, are they allergic or non-allergic rhinitis? So may I ask also, sir, to address that question too?
Sure. So basically the question is about how do we identify the common or uncommon allergens? Yeah. So basically you have mentioned it that we have to be a Sherlock Holmes. And again, history is an important. So you need to be a detective and ask us certain specific questions focused in how the patient is getting exposed to that particular allergen and how the symptom pattern has been faced by the patient. So now in our country, we not only the allergens, we have to ask even what are the exposures to the allergens as well as the irritants. Many a times the patient comes to us with a saying that he is allergic to particular irritant, might be a smoke or might be a pollution or anything. And that's the most common allergen what he has. And he wants us to test for all these things. So we need to ask specific questions with respect to that context. So now, again, history taking with the patient, with the family, and the pattern of the disease, the patient's environment, that is home, office, school, indoor, outdoor. If it is an adult, it's an occupational history. What kind of an occupation and what kind of a symptoms he is facing, and when does he have a symptom and when does he doesn't have a symptom. All these things becomes very, very important when we are taking an history to identify the allergen. Now, let me take few examples which are most common ones and then go for an uncommon ones. Now, if it is a patient who is having perennial symptoms with indoor, and the most common questions what you need to ask, most common allergens what we are suspecting is a dust mite, storage mite, cockroach, pets and molds. Now, if it is an early morning symptoms and the night symptoms, then we know it is a dust mite which we are coming across. If the patient is getting mostly symptoms in the house and more when they get exposed to the books or the old stuffed toys or the grains, the stored grains, then we know it is a storage mite. If the patient is not having any night symptoms on the bedroom, but is having day symptoms and mostly an asthmagenic symptoms and present throughout the year, then we know we are dealing with the cockroaches. If the patient is having pets in the house and symptoms are more severe when they play or spend time with the pets, then we know that we are dealing with the probably a pet as a cause. Again, molds can be both indoor and outdoor. And history tells us that whether in the bathroom or a kitchen where there is a wetness or dampness, or where there is a wallpapers are present, where there is a poor ventilation is present, and if there is a sense of smell of molds, that we know that we are dealing with the molds. So please, I would like to tell the audience, unless you ask a specific question, patient will not come out with all these answers to you. So you need to ask that particular questions. Now, how do we diagnose with respect to the pollen allergies? Now, pollens are a little tricky because, as I told, we are a little challenged with the pollen calendar, and as well as our experience in the botany is not so very well versed with that. So, but however, little classical symptoms are present mostly outdoor, unless the pollens are in and around very close. It can be indoor also, but mostly outdoor. And symptoms are present as a seasonal symptoms. Sometimes you can have a complete perennial indoor allergen, but also a patient might have an outdoor allergen. So you might have a perennial history with a seasonal worsening. So either perennial history with seasonal worsening or only a seasonal symptoms, predominantly outdoor. And generally, typically, the pollens have a character of causing more conjunctivitis than an indoor allergen. I'm not saying that dust mite will not have. I'm saying that pollens generally have a more severe conjunctivitis when it comes to the indoor allergens. So these pointers like seasonal and outdoor and the conjunctivitis tells you that you are dealing with the pollens. Now again, you need to have a pollen calendar and then clarify what months the patient is having symptoms and whether that particular what pollen is dominantly present in that particular season in the particular geographical location. But in pollen calendar, though I told it's quite whole, but it is quite usable also. In a brief nutshell, in our country, because we have about 3 or 4 seasons, if I have to tell, grass pollens are predominantly dominant in March, April, May, June, in the summer and early rainy. And weeds are more dominant in the rainy season and early winter, and tree pollens are more dominant in the winter and early summer. So this is just a crude way, but I would suggest that you need to have a calendar in front of you, and it is available very easily. So it is available. You can keep it in your office and make use of them. So these are the ways where we identify allergens for the things. But one thing which we generally miss it out is an occupational allergen. So many of the times we need to dig into details about the place where they work, what kind of an environment it is. Even a software company, people who are working with a complete AC environment with filters not being cleaned and then the molds being present is very well documented. We have seen those kind of cases. And the patients who work in a food industry, they do come up with a severe rhinitis because of this baker's related asthma or flour related content. People who are working in chemical industry or enzymes industry or even the rubber industries, they do have come across a lot of allergic rhinitis or asthma related symptoms with respect to that particular occupation, which we need to, unless specifically ask. The particular question is, how is your symptoms when you're working or when you're on an off day or when you're travel to a different place, taken a large, let's say about 2 or 3 weeks of off? That tells you that whether there is an involvement of occupational history or not. So this is about an allergic rhinitis. Now coming across a non-allergic rhinitis. So if we are talking about a typical condition, what we are looking at is a vasomotor rhinitis, but there are many other non-allergic rhinitis too. So a patient is usually mostly, I'm not 100%, like mostly an adult, is about in the third decade or end of the second decade or third decade, fourth decade. More common in women when compared to men. Typically, leak is a dominant symptoms. Block is not a dominant symptom, though it can be there, but the dominant symptom is a leak. And the rhinitis is present in such a way the patient tells you that I have to use number of handkerchiefs or hand towels with respect to this particular symptom what I have. And these are the patients who don't have much typical, they do have certain variations with respect to the temperature, humidity, but they don't have a typical variation with respect to what we see like a allergic rhinitis with morning time symptoms more, rest of the times relatively better. That kind of a variability is not seen. And generally, we still go ahead clinically, though we suspect, we still go ahead with an allergy testing. And we see that most common allergens, what we have tested turns out to be negative. So then we say that, okay, this is probably a local allergic rhinitis. That means that patient might still have a allergic component, but it might be restricted only to the nose. So it is called local allergic rhinitis or a vasomotor rhinitis, where probably the components are much different than what we are looking from an allergic perspective. Gustatory rhinitis, what was mentioned, is a totally different entity related to the autonomic nervous system. And these are particularly when the patient is having chewing the food or any kind of a stuff, the rhinitis component starts dominating. And other times, generally the patient is not having any classical symptoms associated with that. So this histories again points us that probably the role of external allergen is unlikely contributing to this scenario kind. So Dr. Shambhu, have answered all the questions or anything left out?
No, thank you, sir. Thank you very much. You had answered, you had clarify these questions very well. Now, may I ask Dr. Vinay Mehta, sir, there is one question raised by Dr. Anita Krishnan from Bangalore. Is allergic conjunctivitis the common associated comorbidity with allergic rhinitis and not
Yes.
asthma? So what is your take?
Yeah, so up to 50%, in fact, some textbooks, they'll call it allergic rhinoconjunctivitis. So up to 50% of the time, patients with allergic rhinitis, especially the pollens, so the trees, grasses, weeds, can cause ocular symptoms. We see that less so with dust mite, less so with molds, so particularly the pollens. Keep in mind that you have mast cells, on the ocular surface. There's also a phenomenon where you have what's called a nasal ocular reflux. So when you have inflammation in the nose, via the trigeminal ganglion, you will see increased production of tears. Think about when you catch a cold. When you have infection, you also get tearing of the eyes. You also get itchiness of the eyes, watering of the eyes, redness of the eyes. So there's also a nasal ocular reflux. And typically, just treating the nose with nasal corticosteroids, nasal antihistamines can help with ocular symptoms. So typically, we start with nasal corticosteroids plus intranasal corticosteroids. Intranasal corticosteroids plus intranasal antihistamines. And if that doesn't control the conjunctivitis symptoms, then you can add a topical antihistamine eye drop. Now, as far as asthma, typically we think of rhinitis, and asthma as one disease. We don't typically think of the eyes. So I think the eyes is maybe separate. Keep in mind that also, very important, sometimes, especially in the elderly population, when I say elderly, even after age 40, you can get dryness of the eyes, particularly in a country with a lot of pollution and dry weather. So a lot of times patients, may have ocular symptoms just because they have dryness of the eyes. And oftentimes that's confused. That's not allergic conjunctivitis, that's dry eye syndrome. The other point I want to make is that nothing is, just like in medicine, nothing is simple. Very rarely do you see a patient with pure allergic rhinitis or pure non-allergic rhinitis. Most patients have a mix, have a combination of allergic and non-allergic rhinitis, which makes the diagnosis even more difficult. For example, patients with non-allergic rhinitis, oftentimes if you do skin tests, I'm sorry. So things that can, if you were sensitized to dust mite, for example, which is a perennial allergen, just the fact that their nose is more primed, they will also react to irritants, perfume, cigarette smoke, changes in weather, changes in barometric pressure. These are typical triggers. These are typical non-allergic triggers. But because they have dust mite sensitivity, they're a little bit more prone. So very important to recognize that your typical average patient will not just have pure allergic rhinitis or pure non-allergic rhinitis. It's often a combination. Same thing with asthma. It's not all allergen driven. It could be irritant driven, exercise driven, infection driven. So these are all things that you need to consider. But it is the most important when it comes to decision making regarding allergen immunotherapy. That is the most important thing, because when you're committing a person to allergen immunotherapy, you're committing the person to at least 3 to 5 years minimum, of therapy, which is very costly, very time consuming. And so it's very important to have a good clinical correlation. You want to select the relevant antigens to and not approach. And the gunshot approach would be to skin test to so many different allergens, and then not knowing, very difficult. The more allergens you're positive to, the more difficult it is then to really go back and say, is this relevant or not? Right? It's very difficult. It's very difficult for you as a physician. It's very difficult for the patient. So my suggestion is when you do skin testing, please also limit, maybe limit yourself to 10 skin tests, 10 allergens, not more than 10. Maybe a few basic common indoor allergens, dust mite, cockroach, maybe one indoor mold, one grass, one tree pollen, one wheat pollen, and that's it. One pet, cat or dog, and that's it. But don't try to don't please restrict how many skin tests, because otherwise the more tests that are positive, the more it will confuse you.
Yeah. Thank you, sir. So we'll have a detailed discussion on skin prick test in the next class, next module. So, but I think you had mentioned a very important issue. Just one question, though it will be discussed in details in the next module, but asked by Dr. Akashdeep from Dhanbad, what is better, SPT or immunocap? Any two-line answer from Dr. Mehta?
Skin prick test.
Yeah.
Skin prick test is it has a higher level of sensitivity and specificity. It is more cost effective. It's an in vivo test, so it's a biological assay. You know directly if there's mast cell degranulation. With the in vitro test, you are, number one, the costs are higher. Number two, you cannot easily select your panel. You cannot easily select which antigen. You often have to write for panels, which are extensive. As opposed to just choosing a couple, doing history and then just selecting a few antigens. Sometimes you're obligated to do the whole panel, which sometimes includes foods, which in my view are irrelevant. Foods do not cause airway disease. Third thing is, which I think is very important, is when you're looking at immunoassays, if you are going to do in vitro blood tests, you really have to get immunocap. In my view, any other immunoassay is not worth. So you make sure it's immunocap from Fadia. That's what you want to get. Now, is there a role for in vitro test? Yes. Situations where we discussed where patients on an interfering medication that they cannot stop. Typically, any tricyclic antidepressant that cannot be stopped, or if you cannot practically do a skin test, the patient has very severe atopic dermatitis, very severe dermatographia, or in situations where recent anaphylaxis, where the mast cells have been depleted of histamine, you cannot do a skin test for about 4 or 6 weeks. In those situations, or in situations where you have the skin tests are negative, but you have a strong suspicion, in those cases, you may want to get an in vitro blood test. But in general, please, do the skin prick test. A lot more cost effective. It allows you to customize, what antigens you test for. And you avoid these false positives because you're not blindly doing, 10, 20, 30 antigens, which are part of most panels. You have 20 or 30 different antigens included, and then you're stuck with the results.
Yeah.
So I'm chipping in here. So truly speaking, yes, the gold standard is skin prick test, we all know, but problem here in India is that we don't get the standardized antigen. That's another real problem where interpretation of the skin prick test may be difficult. Sometimes we get false negative or sometimes false positive.
Yeah.
That's the
Yeah.
thing.
Yeah, I mean, that is true. That is one big issue, but then you also have the same issue with regard to immunotherapy. So you need, for both diagnostic purposes, you need high quality antigens. But more importantly, if you want to start immunotherapy, then you definitely need high quality antigens. So
Yeah.
either way, you'll be stuck. Okay, you may be able to make a diagnosis based on in vitro blood tests, but how are you going to treat the patient? You're limited then.
I think
But I
I think there are
can I
some
just know?
welcome step from our regulators that they had actually emphasizing now on standardized allergen extract preparation, both for investigation purpose and for therapeutic purpose for allergen immunotherapy. And there are certain specific committees are now being formed by our regulators that they are looking after these issues of quality, and most probably we will have the standardized allergen extract that is universally in all part of our country very soon, sir. So
yeah, I just want to
Dr. Shambhu, can I please come in on this standardization thing?
yes,
There
yes,
is
yes.
a misconception, in the whole allergy fraternity that every allergen has got to be standardized. We don't have, Vinay sir would agree with me, we don't have standardized allergen for every allergen, standardized allergen available for every allergen even in US. It's available for just a few dust mites, just two dust mites and a few pollens only. Rest of the allergens, whatever they are non-standardized. Non-standardized does never mean it's a bad quality allergen. Standardization means that batch 1, batch 2, batch 3, batch 4, they are same. The potency is same. There's just a variation of around 5 to 10% between these batches regarding the potency, and that's it. Overall, in my little experience of 10 years in allergy, I have seen that we have come a long way in India as well. We are having very, very good quality allergens nowadays, which because a clinician would definitely come to know about. I mean, how good the allergen is when he correlates it with the history the patient gives, with the other clinical features patient gives. Nowadays, there are some companies, some good companies, which are in India as well, whose antigens, especially pollens, dust mite, even that has become better. Dust mite earlier we used to have reservations. We in Srinagar have done around 14,000 SPTs till date. Our last 5,000 or so SPTs, they have been to a great satisfaction. Prior to that, there was some issue with the dust mites. Nowadays, I see dust mites, especially pollens. In India, we are doing very good. That's my personal point of view. Rest may agree or disagree.
Dr.
And
Shambhu,
one thing I want to mention. One thing I also want to mention is when you do in vitro blood tests and you order these panels, make sure that you are in the panel that you select, that the antigens are relevant to India. Because I've seen so many panels these are Western panels.
Yeah.
Those trees don't even pollinate in India. There's no, and yet you're ordering. So sometimes, be very careful. Try to customize. I would recommend talk to the value people. Say, I don't want customize your panel. I understand, there are very few people who have a setup available to do skin prick testing. So sometimes you may have to do in vitro panel, but at least customize those panels. Make sure that what you are ordering is relevant to India. Okay, yeah. That's critical, because otherwise it's just, you're just wasting money. You're wasting resources.
True.
Dr. Shambhu, I would like to add one point.
Yes, sir. Please.
I totally agree with Dr. Taha Qureshi, who has mentioned it completely. What is the differences between standardization and potency and experience? So we have been always from the last probably about 8-9 years. We are testing the dust mite at least with Hollister standardized allergens along with Indian allergens. And from last 4-5 years, I can say that the skin test, for every patient, we use the dust mite Hollister as well as Indian allergens. and we are not finding any difference between the test results at all. Let it be DP, DF, Blumia, we are getting the same results as allergens. Rarely we find about 1 millimeter difference this side, that side, but we are finding the same results. So I think this gives us quite a lot of confidence in what we are using here also. Thank you.
Thank you, sir. Thank you, sir. So I think there is nothing like that. Our India is now also coming up with good quality allergens, and hopefully that will also help in treating our allergy patients, especially while testing, while starting immunotherapy. That will definitely help us. A few questions we will take because lack of time, we have to finish it. There are many questions in the chat box. Just quick go through on that. Question asked by Dr. Swatantra Burman from Kolkata. The question is like that: the questionnaires that were discussed by Dr. Mehta, can it be used in government sectors as we are overburdened with patients? Yes, there are concerns with time, and the questions are very long. Questionnaires are actually longer, but the thing is that if we build some dedicated allergy clinic in our hospitals, that may be considered to tackle those allergy patients. And I think there we had already discussed how we can customize those questionnaires, how we can have some help from a screening person, so that can reduce the time. We had already discussed that in details. There is another question by Dr. Noor Hussain from Patna. He's asking like that: if IG is more than 500, but there is no symptoms, so whether we should proceed for any treatment for that particular patient or not. The thing is that, Dr. Noor, that already we had discussed that IG is not everything. Everything is history taking. The most important part is history taking. If history is suggestive of something, then we need to proceed. There are many instances when IgE total is normal, but there is presence of allergic symptoms. We need to treat them. And other things like if Ig is more, Ig total is high, but that is not due to allergic disease. That may be due to some other disorders. Already we had discussed in the last module and today also. So we need to consider the history and other issues when Ig is very high. Another question asked by Dr. Munshi, Dr. Bodhan Dashmunshi from Kollani AIMS. He's asking about that Stephen Johnson syndrome and allergy, the connection and assessment, early identification. The thing is that, yes, we use sometimes the allergy terms in a broader way, but we know that Stephen Johnson syndrome is something called as type 4 hypersensitivity reaction. And the last class we had discussed, in type 4 hypersensitivity reactions, there is one subtype, that is type 4C. And in that type 4C, the Stephen Johnson syndrome actually comes. And there is that is not typically what we called about allergy, the type 1 hypersensitivity reaction. Yes, the importance is there. If we can identify early, if we can remove the causative agent, then I think we can prevent the atrocities associated with Stephen Johnson syndrome. Again, one question asked by Dr. Abdus Salam from Guwahati. What is the importance of occupational history in allergies? May I request Professor Nandini Chatterjee, madam, to just address this question from your wisdom, madam. Importance of occupational history in allergy. I think madam had left, but already we had discussed, I think, in details on that occupational history. Dr. Balachandra sir, can you please address this?
Yeah. Thank you. Occupational history is a part of a complete history what we are going to take. Typically, we need to know about the person's occupation, what they are doing, and what all the components they are dealing with that. And whenever you suspect that this could be a probable occupational history, it is very important to get the complete details of chemicals, what is being used, or components, what is being used, the environment, what kind of an environment they are using it, and whether the temperature, humidity, or the protective gears being present or not present, and whether the other members working in the industry are also having the similar kind of a symptoms, or not everybody, but at least some of them having a similar kind of a symptoms or not. Whether the symptoms are present only on the working days or only are present throughout the week or throughout the time. Sometimes 1 or 2 days of uh, off from the work may not be if we capable of able to tell you that this is only an occupational and not a non-occupational. Sometimes we may have to ask if the patient has taken a vacation for a few weeks, whether he was symptomatically better when compared to during the working days. So these kind of an complete details need to be asked. Generally, when we talk about an occupational related history, the most common industry what we are looking at it is I'm specifically looking at airway allergies, considering today's topic. So mostly the food related industry is something which we commonly get associated with that. Chemical industries like manufacturing industry like cement industries or dye industry, these are all the industries again which we are closely associated with the chemical related rhinitis or any kind of a symptoms which can be there. So whenever you suspect a patient, and even when we are looking at an occupational asthma, we need to know the complete ingredients details associated with that. So how do we prove or disprove? This is going to be a big challenge here, because you proving that it is an occupational related has got a big impact on the industry as well as on the patient's job profile. So you need to be very, very careful when you try to label the patient as an occupational related condition. You may have, there are certain tools to examine also, certain questionnaires by which filling up the questionnaires will give you a good amount of idea. Second thing is certain tests done, like say with respect to occupational asthma, you may have to do an peak flow meter in the morning, evening, in the weekdays and week offs. But again, probabilities that patient can not perform that and end up with a more complexity. Preferably a lung function test itself will can guide you about what are the probable impact of the occupational stuff present in that. So I think these are the ways where we will be working it up to evaluate the patient. And before we label and brand it, we should be probably, there are some of the doctors who are working in a industry, that occupational industry itself, there are certain doctors who are employed. Take the help of those particular doctors, visit the centers, reconfirm it, and then put a label on that as an occupational related disease. So it's a long journey, more detailed information, and not easy to get all the information available also. Probably a good clinical correlation and taking the help of a doctor who is working in that industry might help you a lot.
Thank you. Thank you, sir. So there is one question directly asked to Professor Indranil Haldar, sir. So Indranil sir, I think the question to you is by Dr. Adrija Guho from Kolkata. If serum Ig is more than 1000 and Aspergillus specific Ig is more than 0.35 with well-controlled asthma, do I start to treat ABPA in a government setting where other tests are not available?
So, Sambho, that's another really real question that is to be required, whether ABPA can be diagnosed as per the major and the minor criteria, or we can go by one or two criteria. So one is that the history. The first is the asthma with streaky hemoptysis, probably that means we may be having a case of bronchiectasis. So the first thing that we have to know that the patient should be having features of asthma or not. Second, what we can do, even a government setup, CT scan is available. Just find out whether there is central bronchiectasis or not. IG is easily available. We can go for an IG where with the IG is high. Now you can go for the serum specific IgE Aspergillus or IgM Aspergillus. You can go for the major criteria, minor criteria, and see. But with these two, just diagnosing the patient as ABPA in a resource limited setting, probably it is not justified, because we have to give long-term steroids, knowing fully well the side effect of the long-term steroid just on the basis of IgE and symptoms. it is not justified. At least I shouldn't tell that we should be starting long-term steroid, diagnosing it as ABP.
Thank you,
So at
sir.
least CT scan should be done. CT scan should be done. IgE and the major criteria, the Aspergillus specific IgE and they are there. Okay.
Okay, okay. Thank you, sir. So I think already we had delayed Dr. Mehta because there is night. I think we are delaying your sleep, sir. So just last question to be addressed by you, sir, and then we will move to Dr. Balachandra, sir, for some other aspects. So any association of keratoconus with allergic rhinitis as patients, specifically the pediatric patient or even in the adult, have itching and eye rubbing as a frequent symptoms? This is asked by Dr. Rajendran Dinesh Kumar from Bangalore. And whatever you had, one of your slide had shown, Dr. Jimmy from Arunachal also, he had asked one question that in allergic rhinitis, nasal itching is the cardinal feature. No nasal itching means we have to think something else. But in one of the slides, one's on sign and symptom of allergic rhinitis, nasal itching is seen or reported in 46% of patients. Can you please clarify, sir? So she had asked these questions to you. So may I ask to answer these two questions? Already you had told us that there is an overlapping features between allergic and non-allergic rhinitis. But I think sir, your take-home message for us.
So for allergic rhinitis, one of the cardinal features is itching, because remember, this is an Ig-mediated disorder. So you have mast cell activation. One of the mediators released by mast cells is histamine. So it is certainly itching is a cardinal symptom. Versus non-allergic rhinitis, you do not have, there's no Ig involved, there is no mast cell degranulation, therefore there is no histamine being released. So in a very gross manner, if you have itching, then probably histamine is being released, probably you're talking about allergic rhinitis. If there's no itching, it's probably non-allergic rhinitis. Now, the example I gave of ocular symptoms, again, you can have up to 50% of the time when you have allergic rhinitis, you may also have allergic conjunctivitis. Now, the example I gave, if you have a upper respiratory tract infection, however, so if you catch a cold, your eyes may itch. It doesn't mean that this is not an Ig-mediated reaction. That is simply due to a nasal ocular reflux. So inflammation in those can cause, through a local neuronal reflex, it can cause tearing, redness, itching of the eyes. So that's a separate issue. Again, these are general rules, so it's not 100% specific, but in general, if there is less itching, then it's probably not allergic rhinitis. It's probably non-allergic rhinitis. Now, getting to the keratoconus, one of the things that are actually more closely associated with keratoconus is atopic dermatitis. So in children who have so when you see keratoconus, one of the things you may want to inquire about is, does this child have atopic dermatitis? That is a probably better correlation. Then you may think about other things like atopic keratoconjunctivitis would be another. AKC is another disease entity associated with keratoconus. The other thing, since we're talking about different pathognomonic signs, one thing I want to point out on physical exam, which I think is oftentimes not properly understood, is the Denny-Morgan lines. So Denny-Morgan lines are the prominent infraorbital folds. Denny-Morgan lines are actually correlated with atopic dermatitis, not allergic rhinitis. So that's another, oftentimes that's confused. People say, oh, you have, I see Denny Morgan lines, and so that has nothing to do with allergic rhinitis. The shiners that we see, the shiners, the dark circles under the eyes, it is also has nothing to do with allergic rhinitis. It is simply a sign of venous congestion. It means that the nose is obstructed. So whether it's from just, whether it's from allergic rhinitis or non-allergic rhinitis, you cannot differentiate. So just because you have dark circles, that is not a very discriminatory sign. So, so the message here is that, while it is important to do a physical exam, a thorough physical exam, I think the yield is much higher in getting a good clinical history. So the rule of thumb is, and this is ideally, if you can do this, spend 80% of your time should be spent on history, 10% on physical exam, and 10% on diagnostic tests. And again, I realize that, in a setup like India, this may be challenging, but then, that's where you need to have a streamlined approach. You may need the help of your medical assistants. You may need the help of these pre-formed questionnaires that you can have patients fill out while they're in the waiting room. Have them fill them out, have your assistant screen the questionnaires to make your life easy, But I really cannot overemphasize the fact that history is the most important aspect, especially if you are thinking about putting a patient on allergy immunotherapy. History is absolutely critical and paramount, and you cannot shortcut it.
Thank you, sir. Thank you very much. And we're really appreciating your time and your wonderful lecture, sir. So,
okay, thank you. I appreciate it.
Thank you, sir. So now may I request to end this today's panel discussion, may I request Dr. Balachandra, sir, because one of the very key important aspect is how to approach in the anaphylaxis in home. So anaphylaxis action plan, and because we do not have that EpiPen here in India, that is not available. So how we should approach to that? I know you are one of the pioneer in educating, in spreading the awareness on anaphylaxis action plan. So may I request you to show our delegates about that process?
Sure, Dr. Shambhu. Anaphylaxis is something which is presumed as non-existent or a very, very rare entity which happens. And because of this thing, many of the patients who have actual anaphylaxis has been missed out or are being treated in a way where anaphylaxis should be treated they're not getting that kind of a treatment. Sad to say that even in most of the hospitals, anaphylaxis is treated with antihistamine and a steroid, but epinephrine is never considered as the first drug of choice. And many a times anaphylaxis patients are not even aware that it could be evaluated and they could be prevented, and the root cause could be identified. So we in Bangalore, we are located. We see about one patient every week or every 10 days. We see one anaphylaxis for sure in our center. So that's quite a significant number, knowing the severity and impact the disease can cause. So every patient who is anaphylaxis should have an anaphylaxis action plan. So I generally tell them that go to the World Allergy Organization website and type on anaphylaxis. And there is something called a card where gives you a clear-cut information what is anaphylaxis and what is not anaphylaxis in a pictorial way. So like, for example, with urticaria, having a respiratory symptoms or a cardiovascular symptoms or a gastrointestinal symptoms, or you might not have even a skin lesions, but you might have a respiratory compromise with airway compromise and a low blood pressure. And also the 10 steps of management of anaphylaxis is mentioned in the that postcard, which I make the patient, all the patients will be requested to go to the website and download those cards and keep it with them, and tell them that anytime you have an allergic reaction which is significant, please go to the nearest hospital and show them this postcard and tell them that this is how my doctor manages. So it is as simple as that. So it would be great, Dr. Shambhu, to you share that anaphylaxis cards to everyone. So I wouldn't go more detail. I would directly go into how to prepare an epinephrine injection. This has been taught to us by Dr. P.K. Vedantan sir. So how to make your own epinephrine injection and give it to the patient so that he can use it in the time of need. So I will share the video so that you can see that how it has been done. Dr. Shambhu, I have the access to share.
Sir, you can share the screen, sir.
Yeah. Is this video seen?
Yes, sir.
His audio is also heard.
No, sir. Audio is not coming.
Audio is not there.
No, sir.
Yeah, so can you reshare your screen? There is one option, share screen with audio. You need to click on that, sir.
Just a minute.
Yeah, click on the share screen button, bottom left side, share
Just a
audio
minute,
option.
just a minute,
Yes.
Click on the share screen.
There is one.
Share sound.
Yeah, share sound.
Okay. Okay. How to prepare an epinephrine and keep it ready for usage. Why is it necessary? We are living in a country where in India we don't have an EpiPen. EpiPen is a very important life-saving medicine to be taken during anaphylaxis, wherein a patient might have 2 to 5 minutes before he has to take an epinephrine, which can make a difference between life and death. Now, anaphylaxis happens all over the country, all over the globe. But most of the developed countries like Europe, US, they have an EpiPen. They have an automated injector wherein whenever there is a situation of an anaphylaxis, patients are taught how to use it and it has saved millions of lives. Now, same thing, anaphylaxis happens in our country in India. We have epinephrine, but we don't have an auto injector. And because of that, lots of lives are lost. Now, I'll show you how to prepare an epinephrine and give it to your patients so that it can be life-saving. This procedure is taught to me by my professor, Dr. P.K. Vedantan. I've given this epinephrine to several of my patients, and honestly, I should tell that it has saved 3 lives, and those children are alive today only because of this method. Okay. This injection taking doesn't mean that you can take the injection at stay home during the anaphylaxis. Take the injection and rush back to your hospital, nearest hospital, as soon as possible. Also, I would say that whenever you have a possibility, buy an epinephrine auto-injector and keep it with you. But if you don't have it, this might be your life-saving chance. Now, we all know that epinephrine costs only 20 rupees. But an auto-injector costs around 7 or 8,000. Now the same medicine can be life-saving. So how to keep it ready? Many of the times, patients are told, take this injection, go to your nearest hospital and take this injection. You might have an anaphylaxis in a place where you might not have nearest hospital. You don't know where to go. And when you go also, they might not be very convincing to use this unless they're very sure that it's an anaphylaxis. So now see, this is an epinephrine. I would say I'm giving an anaphylaxis preparation for an adult who is about 50 kg. So I would be giving 0.5 ml of epinephrine, 1 in 1,000. So this is how I prepare. And so I would suggest you to prepare. This is a 2 cc syringe wherein I take 0.5 ml of epinephrine. Okay. So now I would change this needle, put another sterile needle. Okay. So this is now epinephrine which is ready. You need to label this. Why it is important is epinephrine is light sensitive, but epinephrine is not temperature sensitive. That means you can use it, keep it in room temperature, but if you expose it to the light, it loses its potency. So by labeling it, you are actually covering the epinephrine. So you are covering, on cover you have written that medicine name, dosage, as well as date of expiry. Now, this much, how do you keep it safely wherever you want to go? This is an spectacle box. Now, this spectacle box will help you to keep this injection safely. Another thing is, in spite of your instructions, patient may not be kind of a mentally prepared. You need to teach them how to use this in your clinic itself. You need to tell them you have to use this injection only on the thigh, in the mid part of the thigh, little anterolaterally. Okay, go deep inside and then push the syringe. When we teach them 2 or 3 times, the patients learn it very easily. And along with that, what we do is, in a piece of paper, we give all the instructions, like what is this contain and how much is the dosage and how to use it, a picture of how to use this. And that paper, we insert it into this particular spectacle box so that when they are they want to know, they can just open it and read it. So now we place the paper inside and then keep the syringe. Following that, now this is like patient can carry anywhere. We give this like 2 or 3 injections. It doesn't cost much. One is kept in the maybe school bag or office bag. One is kept in the car. One is kept in the house. So hopefully the day doesn't come that they need to use. But if the day comes, this will be a life saving. So I hope till we have EpiPen in India, we have to somehow manage like this. But with an instruction, after taking the injection, go to the nearest doctor and tell him that you have taken the injection and this is what your symptoms are.
Thank you, sir. Thank you very much. I think this, sir, we cannot hear you, sir.
Okay. Am I audible now?
Yes. Now audible, sir.
Okay. Yeah, thank you, Dr. Shambhu, for giving opportunity to play this video, knowing the immense value of saving the lives. Also, I would like to tell the audience here, we have developed a module called GAP, Guide to Anaphylaxis Preparedness. This is mainly for the medical fraternity. The complete course is free of cost. Okay, it's about 1.5 hour course, and you get a certification also from Metrain. So anybody can download the Metrain app and start going through the courses. This is Guide to Anaphylaxis Preparedness. And we are launching this course on 15th of this November. So it will be totally free, no need to pay anything. And it has got the complete details of how to approach an anaphylaxis patient, how to treat him in the emergency room, as well as how to approach for identifying the root cause of anaphylaxis, how to be prepared in the school, how to be prepared in the office. So I think the message is to make sure that the whole country, everybody gets prepared about how to manage this case, because if somebody has got a cardiac arrest, the chance of survival is there but less. But if somebody has got an anaphylaxis and you do the right thing, the chance of survival is very, 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 very high. So, and unfortunately, many children and youngsters get involved into this incident and this condition and then end up losing their life, which is not worth enough. Thank you, Dr. Shambhu.
Thanks a lot, sir, for this wonderful initiative. We must appreciate your efforts, sir. And I am requesting you to share the link so that we can also share the link to all our delegates who are participating so that they can directly go through that link. So again, want to thank you, sir. And I am really thankful to Dr. Qureshi, Professor Indranil Haldar, sir. So any final comment from Professor Indranil Haldar, sir?
No, thank you, Shambhu, for the excellent meeting and this August panel. So I'm really overwhelmed, and thank you.
Thank you, sir. Any comment from Dr. Taha Qureshi, sir, please?
Thank you, Dr. Shambhu, for a beautiful session. Vinay sir, Dr. Dr. Haldar, and of course, our dear Bala sir, who is always, there to educate people. Shambhu, you're doing a wonderful, wonderful work. I can see. I really appreciate it. Bala sir already is the boss. And Bala sir, just one thing I know, this is my observation, that there's a lot of adrenaline scare, not among the people, but among our medical fraternities. I mean, is it there? I mean, at your place as well? I can see
Yes,
it. No,
yes. It is. The scare is still there. Lot of medical community, because we always correlate adrenaline to resuscitation. So
right.
that scare is always there, and wherever possible, we educate that, saying that even when you are teaching the patient, we give them three things can happen. One, you're sure it is not an anaphylaxis. That means only dermatological symptom. Otherwise, you're internally you're feeling perfectly all right. Or not, still take an epinephrine.
Right.
We always tell them maximum when you take it on the thigh, 10-15 minutes, you might have little racing heart and little sweating and nothing will go wrong. The same things we are trying to teach the doctor community also. Even if somebody is hypertensive, when you're suspecting an anaphylaxis, give it on the thigh, you're not losing anything. When you have to give it in the IV line, then yes, the risks are to be evaluated and then analyzed in a different way.
Right. Thank you. Thank you, sir.
True, sir. True. And the thing is that pharmacologically, if we also think the adrenaline is something, it is not only going to just stimulate the alpha receptors like alpha 1 or beta 1 like that. It also stimulate the beta 2 receptor. So there would not be such a blood pressure rise as if in case of noradrenaline or other things. So I think this is we need to save our patient's life. So that is the most important thing. And adrenaline is the lifesaver. So we need to increase the awareness on the adrenaline. And I think again, sir, we are really thankful to increase the anaphylaxis literacy, not amongst only to the patient or the patient caregiver, but also to the healthcare professionals, especially the doctors. So once again, thank you, sir. Thanks all the panelists who were there today. And we are really overwhelmed for the blessings by Professor Jyotirmoy Pal, who is the Dean of Indian College of Physicians, who is actually nurturing this course on basics of allergen immunotherapy to increase the awareness on allergy science, allergen immunotherapy amongst the physicians of this country. So again, wish you all a happy Diwali. Today is the festival of light. We always utter the mantra of Tamasoma Jyotirgamaya. At the same time, we will tell Mrityung Ma Amritang Gamaya. So hopefully this type of course will let us know more and help our patients' life. So thank you once again. We will see you in the next module, module 3, and I am hopeful that you all had submitted your post-test questions. Again, we are going to share that in our WhatsApp group and also via email. Those who had not joined the WhatsApp group for this particular course, I am requesting you to please join the WhatsApp group. So again, thank you all and goodbye. Enjoy Diwali. A happy Diwali to all of you. Thank you. Thank you very much.
Goodbye. Happy Diwali.
Happy Diwali. Thank you. Thank you.
Diwali.